Now it's on. A very good afternoon to everyone, and a warm welcome on the August occasion of the Nimhans Tavistock Psychotherapy Conference, titled Psychotherapy Across Epochs and Methods, which has been organized by the Psychotherapy Coordination Committee of Nimhans. Over the next 2 days, leading minds in psychotherapy from India and the United Kingdom will bring us an academic feast that will be sure to delight us all. I would like to invite our Honorable Director, Professor B.N. Gangadhar, to inaugurate this occasion. Thank you.
Good afternoon. Welcome to this very, very important academic program, Training in Psychotherapy. That's a combined program from Nimhans and Tavistock Psychotherapy Group. I must congratulate the coordination team of psychotherapy at Nimhans for having taken this initiative. Perhaps not very often we have done psychotherapy academic programs. To my knowledge, in the recent years, this might have been the first one, unless you remind me that there was something else that had happened in the past. As far as I can recall, nothing had happened on psychotherapy per se as an academic program, and more so psychotherapy across two different institutions coming together and sharing their experiences, wisdom, and skills of psychotherapy. In this context, I think it's been a unique and a first of the type event that is happening. Congratulate the entire team for generating the interest in those who have registered. Welcome to all those who have registered for this program. I'm sure the next 2 days, I believe it's going to be 2 consecutive afternoons, today and tomorrow, when you will be discussing, and you're going to be hearing experts speaking on psychotherapy, sharing their experiences, giving you the tips and the tricks of the trade that you will pick up as part of psychotherapy, which you will, of course, be doing, or perhaps you're already doing with your clients. The entire effort is to augment your skills and ensure that the psychotherapy is most effective from your both time and the efficacy part of it from the patient's point of view. So I wish the academic meeting all the best. This webinar surely will equip you for to become a better psychotherapist in the days to come. Wish you all the best, and I congratulate them once again on this behalf. Thank you.
Thank you. Invite Professor Pratima Murthy, Professor and Head Department of Psychiatry at Nimhans, to say a few words.
First of all, let me echo the welcome that our director has given to all the online participants. I understand it's the response to this has really been overwhelming, and it really tells us how much interest there is in learning psychotherapeutic methods. Of course, I must say that for several decades now, the Department of Psychiatry has been having a very vibrant psychotherapy program, and we've always focused on an eclectic form of psychotherapy that we teach our students. We've had more local conferences to try and assimilate various approaches in psychotherapy, but as the director mentioned, in terms of actually having an international meeting, this perhaps is a milestone event. So it's really wonderful to have 2 large institutions come together to discuss issues that are very, very important in psychotherapy in a wide range of conditions. Many of us, at least at Nimhans, are primarily clinicians who also do psychotherapy along with the other interventions we provide for our patients. I'm sure many people who are participating are psychotherapists in terms of both training and in terms of the primary work that they do. But the whole idea here is to learn lessons from psychotherapy, which we can actually assimilate into our clinical practice and help people along. So this two-afternoon meeting, this conference will actually look at the practice of psychotherapy as it is done at Nimhans, as it is done in Tavistock, the challenges of doing psychotherapy in young people with externalizing symptoms, with internalizing symptoms, people who have undergone trauma, which is a special area of interest of the Tavistock and expertise of the Tavistock Institute. We're going to be looking at the cultural and ethical aspects of physically unexplained symptoms, going to look at the use of technology. And I think that is, again, a first that we're doing something like this on an online platform, which normally is unusual, at least in the area of psychotherapy. And then we round it off with a panel discussion addressing many of your questions. So, I mean, if we would like to make this as interactive as possible, because this is really an exchange of ideas. And I, again, want to echo the compliment that the director paid to the group that has brought this together. 1,800 registrations is a lot of interest. And we hope that this is the trendsetter to really making these programs much more multidisciplinary in future. We already have colleagues from other disciplines who have joined in, but in the years to come, we hope that this can be a very enriching and mutually participatory kind of approach, which brings all the disciplines of mental health doing psychotherapy. So let's hope we have a great 2 afternoons together, and thank you very much.
Thank you, ma'am, for your inspiring words. And without any further ado, I think we should dive straight into our program. So our first session is going to be about psychotherapy training in India and the UK. And the moderator for the session is going to be Dr. Chitra K. She's senior resident at the Department of Psychiatry at Nimhans. And I will hand over to Dr. Chitra to take it over. Thank you.
A very good afternoon to everyone. So I'm
Excuse me, ma'am. You're muted.
sorry. Okay. Yeah. So very good afternoon to everyone. The chairperson of this session on psychotherapy training in India and UK would be Dr. Professor Sanjeev Jain, who's Professor of Psychiatry, Department of Psychiatry, Nimhans, and he did his medical studies at the University of Delhi and his postgraduate training at the Nimhans, and has been a faculty since 1986. He's been a member of the Psychotherapy Supervisors Program from its beginning as a student and as faculty. He's published on psychotherapy of victims of childhood sexual abuse, the work of early psychoanalytically inclined practitioners in India in the 20th century, and also explored the psychological impact of violence that accompanied the independence of India, both in terms of trauma and also notions of identity, citizenship, and personhood. So this is a chairperson. So the speakers of this session would be Dr. Muralidharan K. and Dr. Jessica Ayakle. So to introduce about Dr. Muralidharan K, who will be speaking about psychotherapy training in India. He's a professor of psychiatry and medical superintendent at Nimhans. And he's also the chairperson of Psychotherapy Coordination Committee in the Department of Psychiatry, Nimhans. His areas of interest include mood disorders, non-invasive brain stimulation in psychiatry, psychodynamic psychotherapy, and he has over 100 publications in these areas. Also, he has been doing international collaborative work with NIMH, UBC, Deakin University, Broad Institute. So he's also second editor of Mood Disorders, Indian Journal of Psychological Medicine. And to speak about the second speaker, who's Dr. Jessica Yakle, who speaks about psychotherapy training in UK. So she's a consultant psychiatrist in forensic psychotherapy and director of the Portman Clinic and director of medical education, Tavistock and Portman NHS Foundation Trust. She's also a fellow of the British Psychoanalytic Society and editor of the journal Psychoanalytic Psychotherapy. She specializes in the psychotherapeutic treatment of people presenting with violent and sexual problems. She has published widely on topics including psychological therapies, medical education, violence, risk assessment, prison health, and antisocial personality disorder. She's a research lead for the Royal College of Psychiatrists Psychotherapy faculty and for the British Psychoanalytic Council. She's currently leading the national development and implementation of new services for a multi-site randomized controlled trial of mentalization-based treatment for antisocial personality disorder as a part of the UK government's National Personality Disorder Offender Pathway Strategy. We welcome you, ma'am and sir, and over to the chairperson, Dr. Sanjeev Jain, to continue with the session. Thank you.
Thank you, Chitra, and thank you, my colleagues in the psychotherapy training group for having me here. I look forward to this. As you would know, the world had 11 September is a kind of a landmark event in the contemporary history of our societies, and it is right that we are starting the psychotherapy training program, the conference, on a day which is kind of seared into our memories because of the trauma and the disruptions that it caused. But we'll start with the psychotherapy training in India, and my colleague, Dr. Muralidharan Keswan, who's been a part of the department and both as a student and as a colleague for many years now. And he obviously chairs the coordination committee. So here's to you, Murali. Carry on. Thank you.
Thank you. Thank you, sir. A very good afternoon to all the delegates who've joined from India, and a very good morning to people in the UK. And it is indeed a great honor for me to be here and to be giving the first talk of what is a historic event. Nimhans and Tavistock joining hands together for a psychotherapy conference. We hope that this would be the first, the joint conference, the first of many. And we also hope that this would be the start of a long collaboration in psychotherapy research and training between these two institutes. So the outline of my presentation would be as follows. I'll start with a few slides setting the context for psychotherapy training in India, followed by a few slides which talk about 100 years of what is referred to as Western psychotherapy in India, a few slides on psychotherapy training at Nimhans, and happy to say that we are almost completing 4 decades of psychotherapy training. Then I'll have a few slides about what is happening in terms of psychotherapy training in the rest of the country, and with a few points about the future directions. So to set the context, no talk about psychotherapy in India can ignore the contributions of the 2 epics. The first one, of course, is the Ramayana, where in the context of psychotherapy, the episode wherein Jambavan helps Hanuman realize his true potential is something that is spoken about as one of the earliest descriptions of psychotherapy. And then you have the Bhagavad Gita, the holy text of the Hindus, where Arjuna in the battlefield, when he is overcome with turmoil, is helped to resolve his inner conflicts by Lord Krishna. And these two are often cited as some of the earliest examples of psychotherapy in Indian mythological literature. In more recent times, we have literature that talks about Buddha and his discourse with Pattodana, a mendicant, and the interaction between them is cited as one of the earliest examples of psychotherapeutic interaction. Of course, we have other forms of therapy that are quite native to India, including the different forms of yoga and meditation, all of which, at the end of the day, talk about how to attain inner peace and to overcome turmoil that one experiences in one's mind. And some of the concepts that are quite unique to India also include the Guru-Chela relationship, where the relationship between the teacher and the student is one of submission. And that is something that is encountered frequently in the psychotherapeutic setting. So for more information about the role of Indian mythology in therapeutic wisdom, there is a good article by Dr. Shyam Sundar, which was published in 1993 in the American Journal of Psychotherapy. And there is a lot of information about how anecdotes from Indian mythology can be used for psychotherapeutic application in the cultural context. So moving on to the so-called 100 years of Western psychotherapy in India. Psychotherapy was initially introduced to us by Dr. Girindra Shekhar Bose, a medical doctor and a psychologist, who wrote a concept paper on the concept of repression in the year 1921. And he is widely regarded as the father of psychoanalysis in India. The correspondence between Freud and Girindra Shekhar Bose is something that talks about how the concept of Western psychotherapy actually took root in India, and how Freud was able to validate some of the concepts that Girindra Shekhar Bose had postulated. He was also instrumental in founding the Indian Psychoanalytical Society, which is still housed in Kolkata. So continuing with 100 years of Western psychotherapy, so there are some articles that try to capture the progress of psychotherapy training in India. One such article is this article by Professor Neki that was published in 1975. So in which Professor Neki says that if psychotherapy is defined as an interpersonal method of mitigating suffering, then many psychotherapeutic systems have existed in India for a long time. Some such include the soul analysis by Dr. Satyanand, who was a professor of psychiatry at the All India Institute of Medical Sciences. Hawke, in her paper titled Psychotherapy and Psychoanalysis, did mention that it was difficult for therapists trained abroad to practice psychotherapy in India. Some of the reasons for this difficulty or failure of the so-called Western psychotherapy at that time was postulated to be poverty, illiteracy, the increased dependence on folklorism, and the importance that was attached to traditional value by the patients in India. The article concluded by saying, Western psychotherapy is hardly applicable to the multitude of Indians, except for a few westernized Indians living in large cosmopolitan cities. So if we look at the literature on psychotherapy that was there in the last 100 years, some of them I've highlighted here. Most of them refer to psychotherapy as Western psychotherapy. This article by Dr. Surya and Jairam talk about how very few Indian psychiatrists practice Western psychotherapy in isolated pockets in India. The paper by Dr. Verma speaks about Western psychotherapy again, but the improvement here is that Western psychotherapy is practiced in a small but a significant extent in India. So there was some acknowledgement that yes, the practice of psychotherapy seems to have increased. The future of psychotherapy in India is hard to predict, but lies in rediscovering traditional strengths. So again, most of the writers or authors would go back to pointing out that we need to make sure that the traditional systems are taken into account while we practice psychotherapy. Interestingly, an article written by Hawke, again, in the year 1990, that is about 25 years after she first published, she says that yet, in view of the present trends towards modernization, Western psychotherapy does have a place in India. So from saying that it is very difficult for a Western-trained psychotherapist to practice in India to acknowledging that, yes, there seems to be a place, that was a remarkable improvement in terms of psychotherapy practice in India. Of course, she did mention that most of the psychotherapy was in the form of behavior therapy or biofeedback. So in this context, an entire issue of the Indian Journal of Psychological Medicine carried some articles on psychotherapy in India, which tried to answer one single question. Is the so-called Western psychotherapy effective in India? And 3 or 4 eminent personalities were invited to share their viewpoints or opinions, and this is what they had to say. The Western psychotherapy is not out of place in the Indian context. It is necessary for the therapist to develop sensitivities that would help them cater to the needs of the client. So from saying that Western psychotherapy is not probably useful in India to saying that yes, the therapist should develop sensitivities to address the client is something that was a dramatic change, or we could call a more or less paradigm shift in thinking. The authors also talk about the authority role that is assigned by the patient to the therapist, and why a few sessions are important for the therapist to be able to break this role that is assigned and to be able to take the psychotherapy sessions forward. The authors also talk about repatterning the use of various components of psychotherapy to tailor it to the Indian client. So we could see that over a period of time, there was more acceptance, even though it was probably gradual, there was acceptance of the concepts of psychotherapy and that it may be applicable to the Indian context. So in this background, we'll talk about the psychotherapy training at Nimhans. Happy to say that we are seeing 4 decades of psychotherapy training at Nimhans, and the psychotherapy supervision and training has continued fairly strongly over the last 4 decades. So my reference point for my talk about psychotherapy at Nimhans is this article that was published in 1993. And most of the people who are authors in this article were instrumental in establishing the psychotherapy training program at Nimhans. And at this point, I'd like to take a moment to place on record our appreciation and gratitude to the people who were involved in starting the psychotherapy program. And this is what we would actually refer to as pioneering work in terms of psychiatry education and psychotherapy training. So thank you all so much. It is indeed a matter of pride that many of them are actually a part of this psychotherapy symposium over the next 2 days. So we look forward to hearing from them and hoping that they would share their knowledge about how they brought this program over 4 decades. So the psychotherapy program at Nimhans started off with a pilot for over 4 years by Dr. Shyam Sundar, who tried to bring in the concepts of psychotherapy and sensitize students towards psychotherapy. It was formally launched in August 1983, as the article itself says. A formal mandatory psychotherapy training program for psychiatry residents at Nimhans was started in 1983, the accent being on the word mandatory. And happy to say that over 37 years, we have trained 900 plus psychiatry residents in psychotherapy, which is a remarkable number. And it's a matter of pride for us to be a part of the group that has trained some of these residents. So to compare what happened in 93 and 2020. So the supervisors group in 93 consisted of about 11 members who were actively involved in the supervision. Currently, the number of supervisors stands at 34. Of course, a lot of them have been supervisors and have superannuated or have left the institute. So the total number of supervisors would be a lot more than that 34. In addition, we have senior residents or specialists in psychiatry who are also part of the supervisors group. As the head of the department mentioned a little while ago, the training here is in terms of brief dynamic therapy, cognitive behavior therapy, and supportive psychotherapies, and we practice a somewhat eclectic kind of psychotherapy. The supervision of the psychotherapy activity is carried out by the Psychotherapy Coordination Committee. So what are the phases of training? As in 1993, even in 2020, even over the years, we start off with a communication skills workshop for the students when they join the residency program. This is followed up by interview exercises which are carried out in smaller groups with the respective supervisors once the students are allocated to work under particular supervisors. The theoretical reinforcement usually happens in the second year of the MD psychiatry residency training, where a series of lectures are held to talk about the different theoretical aspects of various schools of psychology and psychotherapy. And of course, the improvement from 1993 till 2020 remains the use of technology in this training program, especially in the current context, given that COVID has made it difficult for us to have in-person training or in-person exercises. In terms of supervision, each supervisor is allotted about 3 or 4 students who meet regularly to discuss clients whom they may have seen in therapy or had sessions with over the last week or so. So both peer and group supervision happens. Every Tuesday, 4 to 5 p.m. is designated as the psychotherapy supervision time. The individual trainees discuss their sessions in this, and all the peers as well as the supervisor give their inputs towards the session that was held and for subsequent sessions. Of course, the clients are aware that this kind of discussion happens regarding the session that has been held with them. And we've moved over to the electronic format for record keeping and discussion for some time now. In terms of assessments, there is an initial assessment which is more informal, which helps the supervisor to decide what extra skill training is required for the resident. There is a longitudinal assessment that is done by the supervisor, and marks are allocated at the end of the period of training. The final assessment is more of a cross-sectional examination kind of assessment where supervisors who are not the primary supervisor of the trainee examine the trainee on their performance as well as the theoretical understanding of psychotherapy. And we have also initiated this process of giving awards for the best psychotherapy program done by a resident since the year 2010. So the assessment and rewards is something that has been initiated over the last few years. So this is the calendar of psychotherapy training at Nimhans. So the residents are allocated to supervisors in the very second month of joining Nimhans. A communication skills workshop is held for them at the beginning of their residency. And subsequently, they meet every week with the respective supervisors, undergo the training that I've outlined earlier, and we conclude with an examination for the students in the 32nd month of their training. So in terms of future direction, it's interesting to see what was envisaged in 1993. So one of the things that the article spoke about was measuring and training in desirable therapist qualities, validation of the training program, and short training workshops for supervisors. Cut to 2020, we are now talking about the role of telepsychotherapy in psychotherapy practice and training. We need to look at the validation of telepsychotherapy program now that this is going to be a newer introduction into the practice of psychotherapy. However, some of the older points still remain. Measuring and training in desirable therapist qualities still continue to be important. And of course, like in 1993, this short-term training of supervisors is extremely important in order to take the psychotherapy program forward. A few extra or important things that we have added and enhanced since the article was written. Since the 1960s, we have a family therapy program at Nimhans, and we have a family psychiatry center here since 1975. The residents are trained in various forms of couple and family interventions. They undergo 1 full month of training, and that amounts to about 200 hours of supervised psychotherapy training. In addition, there is a behavioral medicine unit which has been established here since 1974. The psychiatry residents learn integrative cognitive behavior and cognitive and behavior therapy along with third wave therapy is here. And like with family therapy, behavioral therapy posting is for 1 full month for psychiatry residents. So there is a lot of emphasis that is laid on learning psychotherapeutic techniques during the course of residency. Of course, I have not spoken about the psychotherapy training that is given to students in clinical psychology, psychiatric social work, and nursing, because that would be an entire hour in itself. So I'm just focusing on the training that residents of psychiatry get at the institute. So moving on to the bird's eye view of psychotherapy training in India. So I spoke to some of my contemporaries in the other important psychiatry institutes in the country, and this is what we have in terms of the psychotherapy training. KMC Manipal has a structured training program, which is quite similar to what we have in Nimhans, though not as detailed since 92-93. JIPMER has more of an individual supervision in terms of psychotherapy, where a particular student discusses with a supervisor. The group supervision is not something that is practiced there. In CIP Ranchi, which is the oldest mental hospital in the country, there is no structured psychotherapy training program as of now. They get trained in eclectic forms of therapy by different consultants. IMH Chennai does not have a psychotherapy training program. AIMS New Delhi and PGI Chandigarh do not have a structured training program. Chandigarh, there is more of an individual supervision, and I think the residents are expected to do about 100 hours of supervised psychotherapy during the residency period. So, despite the psychotherapy practice being followed in India for more than 100 years, we can see that a lot of institutions in India still do not have a very formal or structured psychotherapy training program, and that is a gap that needs to be filled in the years to come. So looking ahead, the psychotherapy training and supervision still remains one of those roads that are less traveled. I'm glad to say that some of our senior faculty members in the department took the road that was less traveled, and thankfully because of that, 4 decades down the line, we have a very, very well-established psychotherapy training program at Nimhans. But the truth remains that psychotherapy training remains the road less traveled. The scenario seems to be better than about 30 years ago. The psychiatrists and clients have contributed to this change. Client, because the education, liberalization, the advent of technology has made it possible for the clients to be more accepting of psychotherapy than what it was about 30 years ago. Structured training across psychiatry institutes and medical colleges need to be developed. That is a need of the hour. Training of supervisors remains an important issue, and that is also one of the major bottlenecks in terms of establishing psychotherapy programs and institutes across the country. Utilizing technology to enhance training and service provision is another important aspect that we need to look into. And networking and collaboration with other centers is an important thing that would take psychotherapy forward in the coming decades. Particularly, collaboration with institutes like Tavistock would help us strengthen our psychotherapy training and research programs in India. More importantly, we should be absolutely sure that we are training our therapy supervisors to do exactly what they are trained to do. So the validation of psychotherapeutic training is something that is extremely important. looking ahead. So with these few words, I'd like to place on record my appreciation to a few people. Dr. Shekhar Sheshadri, my guru who taught me psychotherapy. I think it's important for me to place on record my appreciation for his training. Thank you, sir. The clients and trainees over the years who helped us learn and understand psychotherapy better. And of course, the Psychotherapy Coordination Committee, the team which has helped us bring this program together. Dr. Matthew Verghese and Dr. Paulomi for your information and slides about family therapy and behavior therapy. Thank you so much. And the Psychotherapy Supervisors Group. So with these few words, thank you so much for your attention.
Thank you, Murli. We can perhaps move straight on to the next speaker. I believe we'll have questions at the end of it, so please do send your questions to the moderator.
Jessica, you're on mute. Dr. Jessica, you're on mute.
Okay, I'm sorry.
Yeah, that's better. Yeah.
Sorry, I've been having problems getting onto my Zoom, and I would like to. Okay,
you're right there. We can hear you and see you.
I'd like to show my PowerPoint, but I'm not sure how I can get it. How I can screen share. Okay. Let me just see if I can do that. Okay. Okay.
Oh yeah.
Yeah, and let me just get it on. Sorry about this. Sorry. Okay. Okay. Right. And I seem to have stopped my video as well. Okay. I'm sorry about this. Thank you very much. I feel honored to be here. And this is the first time I've done an international Zoom conference. So bear with me. So I'm a consultant psychiatrist specializing in forensic psychotherapy in London, in the UK. And forensic psychotherapy is one of the smallest, if not the smallest, subspecialties of psychiatry. Just very briefly about me, I trained in psychiatry in the 1990s at the Maudsley Hospital. And then I got my first consultant post in psychotherapy in 2003 at the Portman Clinic, which is part of the Tavistock and Portman, where I remained until today. I fear my presentation isn't going to be as informative and full as the previous presentation. I'm really just giving you an overview of the structure of psychotherapy training in psychiatry in the UK and some of the difficulties. Sorry. Okay. So just to say a little bit about the history of psychotherapy training in psychiatry, I think I was finding it difficult to get historical details, but certainly when I was first trained 25 years ago, and I think for probably 2 decades before that, so in the 1970s, psychotherapy became integrated into psychiatry training. And at the time, it was very much influenced by psychoanalysts. So the psychotherapists, and actually also many of the psychiatrists, I think, who weren't necessarily just practicing psychotherapy, were psychoanalysts. So there was a big psychoanalytic influence. Now, that sort of gradually waned, as it has internationally, with the rise of CBT in the evidence base, but also with the newer antipsychotic medications which were coming in, particularly clozapine, which came in when I started training at the Maudsley Hospital in 1993. And prior to that, there had been a strong influence, not just in psychoanalytic or psychoanalysis, but also in social psychiatry. And they were very much linked, and together with family therapy. And that's very much waned again, I think, in the last 25 years in its importance within psychiatry. However, I do feel that in the last 10 years, more and more trainees in psychiatry are becoming much more interested in psychoanalytic ideas and even doing the psychoanalytic training again. So I feel it's still a hopeful time. So I want to now just give a structure of psychiatry training in the UK as it is now and where psychotherapy fits into that. So all psychiatrists do an initial 3 years in what's called core training, which is usually 6-monthly placements, so 6-month placements. And this has to be in general psychiatry, so at least 2 placements, one inpatient and community. And then they also have an opportunity to do 6 months in more specialized placements, which will vary according to the scheme, according to the region. But they may include placements, for example, in addictions, child and adolescent psychiatry, forensic psychiatry, and in some places they can also do 6 months in psychotherapy, but that's obviously quite a short period of time, and they within those 6 months wouldn't have the opportunity to do long-term treatment. So at the end of those 3 years, they then do the exam, the MRC Psych exam. And then if they're successful, they go on to higher training in their chosen specialty for a further 3 years, which leads to gaining a certificate of completion in training, which scores a CCT, which allows them to practice as a consultant psychiatrist. So most trainees will do general psychiatry, but then the other specialties in order of size are old age psychiatry, forensic psychiatry, child and adolescent psychiatry, psychiatry of learning disability, and what we're calling now medical psychotherapy. That is the psychotherapy specialty within psychiatry. And that, as you can see, is the smallest specialty, with about, I think, 70 trainees overall in the UK. And again, it was very difficult to get those figures, which says something about I think that there is a little bit of fragmentation of training in general at the moment. So just very briefly, to those there are some subspecialties. So in general psychiatry, you can do 2 years of general psychiatry and then 1 year in these specialties: substance misuse, liaison, rehabilitation, perinatal, neuropsychiatry, and eating disorder psychiatry. This is a census done last year of the, of the number of consultant posts. And as I say, I could not get the number of trainee posts. So this is the number of consultant posts broken down per specialty across the UK. And you can see that medical psychotherapy there is the smallest. I think it's still just about the smallest, maybe along with neuropsychiatry as a proportion. So it only makes up 1.6% last year of the specialties in the overall psychiatry. So obviously, general adult psychiatry is the most common, followed by old age, as I was saying. So you can see that we really are in the minority here, but I think we very much punch above our weight. And I think we do still very much have a voice within psychiatry and in the Royal College of Psychiatrists. Sorry. Okay. So part of this is that although we're a small specialty, in other words, those of us who have gone on to train and we're just practicing as medical psychotherapists, unlike all the other specialties, psychotherapy is integrated into the training, in both core training and higher training. So all psychiatrists, starting in their core training, have to do at least 2 supervised psychotherapy cases in 2 different modalities and of 2 different durations, i.e. short-term or long-term. So long-term is a year, short-term counts as 12 to 20 sessions. And the majority of trainees will do their short case in CBT and the long case in psychoanalytic or psychodynamic. I'm using those terms a bit interchangeably here. Do the long case. And also, all trainees have to do a case-based discussion group. We would say bar-link group, although there has been some discussion from the CBT therapists don't like us calling it a bar-link group because that is obviously psychoanalytic connotations, given that Michael Barlint, who originally started these groups for GPs in the 1950s to discuss their patients and particularly the emotional aspects of the doctor-patient relationship, and he was a psychoanalyst. But in any case, all core trainees have to be in a bar-link group for at least a year, supervised either by a consultant psychiatrist specialized in psychotherapy or by one of the higher trainees who's specializing in psychotherapy. And in each rotation, psychiatry rotation across the country, core rotations, there has to be what's called a psychotherapy tutor, who is a psychiatrist specialized in medical psychotherapy, to oversee and organize this. So I think that really says something about psychiatry still, is that psychotherapy is actually taken very seriously. Just briefly say, what are the aims of psychotherapy in psychiatry training? What are we trying to achieve? So this is actually taken from the curriculum. To contribute to the training of future consultant psychiatrists in all branches of psychiatry who are psychotherapeutically informed, display advanced emotional literacy, and can deliver some psychological treatments and interventions. Such psychiatrists will be able to account for clinical phenomena in psychological terms, deploy advanced communication skills, display advanced emotional intelligence in dealings with patients and colleagues and yourself, refer patients appropriately for formal psychotherapies, jointly manage patients receiving psychotherapy, and deliver basic psychotherapeutic treatments and strategies where appropriate. So coming on to specialty training, so these are the higher trainees who want to specialize in medical psychotherapy. So it's a 3-year training. They major, if you like, in one of the 3 major modes. So they would be psychodynamic, or in a very few areas you could do interpersonal therapy, but mainly psychodynamic, or what we, psychoanalytic psychodynamic, CBT, or systemic family therapy. Now, the majority of patients major in psychodynamic, and a few do CBT. And what majoring means is that the majority of the patients that they will see will be in that mode. It's now a competency-based curriculum, which means you have to be seen or assessed to gain the relevant competencies in all different areas. And that has been a bit complicated to, how do we know they've gained the competencies? In the past, when I was training, it was actually number of hours. So we had to do 900 hours of seeing psychotherapy of your main mode. So for me, it was in psychoanalytic, psychodynamic psychotherapy, and then 100 hours in the other 2 modalities. So you are exposed to the other modes. So you are, you come out of this being trained in the 3 major modes. Now, the previous speaker talked about the 3rd wave therapies, which I will be talking about later in my talk on personality disorder, but they include the therapies coming out of each of these major sort of modes, if you like. So within psychodynamic, it might be mentalization-based treatment, MBT. From CBT, it might be DBT, dialectical behavioral, and then within, also mindfulness. So trainees also get exposure to these therapies, but again, that would depend on the region and the availability of specialists who deliver these therapies or trained in these therapies, the majority of whom are psychologists. So in the UK, and this is partly a problem as well, is that the majority of psychotherapies delivered within the National Health Service are psychologists, not psychiatrists. And that is a problem. I should also say that I am talking about the National Health Service here. I'm not talking about psychotherapy external to the National Health Service in the private sector. We're training psychiatrists with the idea that they're going to remain within the National Health Service. So within these 3 years of training, they will have 2 or 3 placements. So either 3 one-year placements or 2 1.5-year placements, which may include a personality disorder service. In the past, there were psychotherapy departments which offered a range of psychotherapies, including traditional psychoanalytic psychotherapy. With the move towards more evidence-based psychotherapies, quite a few of those more traditional psychotherapy services have been cut, or they have been diminished in size, with the rise of personality disorder services who are dedicated to treating individuals with personality disorder, but not so much patients with depression and anxiety, who are more now seen by therapists in primary care with our IAP services. So our trainees will also gain experience in supervision. That's how to supervise, in running reflective practice or bar-link groups. And as with all other higher trainees in psychiatry, they need to gain experience in audit, research, management, leadership, and teaching. I should say that research is neglected in psychotherapy training. This is partly because they have to do so many other things, including their personal psychotherapy. But I think it's also due to the long-standing antipathy of the psychoanalytic profession towards research, which I really think has not been in their, or even I'm a psychoanalyst, best interest. And then with the rise of evidence-based treatments and the big evidence base the CBT has, we really need to, as psychoanalytic psychotherapists, demonstrate in robust empirical empirical research that our psychotherapies are also effective. And there is a good amount of evidence that is the case. So we really do need to try and raise the time in which, or encourage our trainees and trainers to embed research in the curriculum for specialty training in medical psychotherapy. As I say, these trainees have to have their own personal psychotherapy. That's actually mandated in the curriculum, which is mandated from the General Medical Council, our regulatory council, so the GMC. So that's actually quite an achievement, I think, from my point of view, that they need to have their own personal therapy. And in fact, I would be very much in favour of all psychiatrists having personal therapy. But anyway, so for those majoring in psychoanalytic psychotherapy, it has to be 3 times a week, and for CBT, once a week. There are also dual trainings, which are becoming more popular. So for psychotherapy, there are 3 dual trainings where you do it 5 years now of specialty. And the ones involving psychotherapy are general psychiatry and medical psychotherapy. So 2 years of both, and then one of a subspecialty. Sorry, 2 years in general psychiatry, 3 years in medical psychotherapy. And then what I'm involved in is forensic psychotherapy, which is dual training in forensic psychiatry and medical psychotherapy. And the dual trainings, particularly for general psychiatry and medical psychotherapy, are becoming more popular than just doing a single training in medical psychotherapy. And that is mainly because, one of the reasons is because there are not very many consultant posts in medical psychotherapy and purely medical psychotherapy. So this will give them more opportunities of finding a post in general psychiatry, but with a psychotherapy element. And I think it's good because it's increasing the profile of and the skills of general psychiatrists in psychotherapy. But on the other hand, there is a worry that actual dedicated posts, and then worry that will extend to the whole specialty or faculty, that we will no longer have a separate specialists in psychotherapy, medical psychotherapy and forensic psychotherapy. This is my final slide. So these are the concerns, some of the concerns I have about the future of medical psychotherapy. So there is a lack of medical psychotherapy posts. They have been gradually cut over the years, even though the General Medical Council says that the psychotherapy tutor, so that's the person who oversees the core psychotherapy training, that they have to be a medical psychotherapist. So in other words, they're saying that for training, at least, we have to have medical psychotherapy consultants. We obviously think for clinical purposes as well, to treat patients, we still need psychotherapists. I feel that psychotherapy, it is still very integrated in the curriculum, and I very much feel it has been supported at a high level within the college, within the Royal College of Psychiatrists, with the current and previous presidents of the Royal College and other senior members very much supporting psychotherapy. But I think also in that there still is a lack of familiarity, maybe, and in some cases an antagonism towards psychotherapy, the importance of psychotherapy, particularly psychoanalytic psychotherapy in general psychiatrists. But as I say, I think more and more trainees are interested. I've already talked about the predominance of CBT. I've talked about the drift towards dual training. With the psychotherapy being embedded in training, I should have said that higher trainees in all specialties, not just medical psychotherapy, are meant to continue some training in psychotherapy, so throughout training, but not all do. Patients are becoming much more complex, so are they suitable to be seen by core trainees? We're very expensive compared to psychotherapists who are non-medical. And as I say, within the National Health Service, the majority of talking therapies are delivered by psychologists. So what makes us special? Why are we? And we argue that we know about the body. We maybe are better at leadership. It's a bit controversial saying that, but that is a problem. And finally, how important is it to do an external training, such as train as a psychoanalyst, which I did separately? And when I was training in psychiatry, many more people were doing the psychoanalytic training than came after me. In fact, as I've said, with the increased interest now in psychoanalytic psychotherapies, more psychiatrists are actually now doing external psychoanalytic trainings. So I want to finish there. Thank you very much.
Thank you. Thank you. I think we have a few questions waiting for you. So, Chitra, if you can, there are two specific questions. How to inculcate good skills for psychotherapy in trainees? That's a very tall order, but if you can answer that.
I think since you have been associated with psychotherapy training for more than 40 years, you're the best person to answer that question, Dr. Jain.
Well, let's take the second one first. Can either of you, Murli or Jessica, give information regarding the specific courses through which one could learn psychotherapy in India and the UK, in whatever form, either as a brief course or as a fellowship? Are there opportunities for that? For example, in the Tavistock, when people come in for short fellowships and learn therapy skills?
Yes, well, I can talk about the Tavistock. So we do have an international visitors program, which I would like to promote, where psychiatrists from abroad can come for up to 3 months to observe and learn what goes on at the Tavistock. But in terms of actual trainings, there are a variety of trainings that we offer from the Tavistock. Some of which include a sort of proper training, if you like, in both child and adolescent psychotherapy, and there are 3 of increasing levels of complexity, if you like, in psychotherapy. But they would require, obviously, the person to live here and also to pay. They're quite costly. But we also have more short-term, lecture series where you wouldn't actually be seeing a patient, you'd be exposed to psychotherapy ideas. So there is a range of courses, and we could certainly, make that available. We could, to people if they're interested.
I think that would be very useful if, at least to the members of whoever's attending, we could share that as part of the organizing committee's efforts. There's some information about these courses.
I'd like to try and answer the first
question. Please do.
I think it raises a tricky question about how much you can teach and how much, depends on your personality. And so even thinking of empathy, you wouldn't quite put empathy as a skill, but it's an essential, it's put in the curriculum as essential quality for all doctors. And, how much can you actually teach that? And I should say with skills, we actually start off with medical students, and I didn't say anything about psychotherapy training in medical schools, but I'm very involved in that. And the Royal College of Psychiatrists has done some good work over the last 6 years in trying to embed Barlink groups again in medical schools, so that medical students have opportunities to be exposed to not just psychodynamic ideas, but more generally how to think about the doctor-patient relationship, but also particularly the emotional aspects, what to do with your own emotions. And that encourages some students to go on to do psychiatry, and then a few maybe into psychotherapy. And again, we would hope that translates into skills. I mean, it is very difficult. How do you learn skills? How do you translate theory, into skills? And obviously, doing things in practice, seeing your own psychotherapy patient, observing others. Although a problem with psychotherapy patients is that you can't usually have anyone, sitting in the room. So I'm not sure I've answered the question, but yeah.
That's a very interesting point. So when exactly in medical education does this trainings begin? Right in the first year, I believe, in the UK, or right from the time they start seeing patients directly?
No. Yes. Well, we offer Barlink groups actually from the time that they start seeing patients. But I think in medical schools, psychiatry has been marginalized. And so on the one hand, whilst there's been the promotion of whole person medicine, and more longitudinal sort of following up patients, I think in some medical schools, the actual time spent in psychiatry placements has diminished. The Royal College of Psychiatrists are doing a huge amount of work to encourage medical students to choose psychiatry, which has always been one of the least popular placements. But, as I say, we've really tried, I've been involved in this in the last 20 years, is increasing psychotherapy in medical. And medical students are so keen, they really are. And then something happens once they get exposed to, medicine and the hard work and everything. But at the beginning, they're so keen to learn about,
I would broadly agree that, for psychotherapy training, I don't think there's anything, one has to read the books, but one should also be open to the book of life and learn about patients' experiences and empathize with the patients' situations. In a diverse country like ours, patients can come literally from the street, living on the street and slums, to people who are fluent software engineers. And to do psychotherapy across all these spectrum of class and language poses challenges, but psychiatrists have to learn to do that. So I think it's, and the book of life, I guess, is as important as reading and more reading of all the books of psychoanalysis and all the reformulations and the therapies and social psychiatry to some extent. Because although Murli talked about psychotherapy as the Western thing, British doctors or Indian doctors were using words like hysteria and doing therapy way back in the 1800s. So we have case notes from 1870s and 1880s doing therapy. And people like Berkeley and Winnicott, who both worked in India, have had a huge impact on psychoanalytical thought. So it's not. So things have gone back and forth, and many aspects of two of the ex-directors of Nimhans, Professor Masani, ended up being therapists in the NHS. So there has been a lot of back and forth between psychotherapy practice, for example, at Nimhans and the UK. And I think we would need to learn a lot more from each other's societies and settings to be able to take this forward.
Can I just add to that? I'm sorry, it was probably short of time, but I think what I've really omitted from this talk, and it is a problem, is cultural aspect, and that really has not been sort of thought about enough. Is we have been very Western or even British orientated, and that is there's been a problem in psychiatry in general, and with the whole Black Lives Matter movement, it's really come to the fore. But that's it has been a bit late, but we're very, very conscious of that. And in fact, all the curricula of all medical specialties in the country are being updated at the moment as we speak. And I think that's an opportunity to get that. But that has really been a problem.
One of my most fascinating case notes, which I came across, was a British doctor doing therapy with a Pushto speaker to treat his addiction through an Urdu-speaking Indian soldier. So he was working across 3 languages and still doing therapy and still maintaining notes, which is quite impressive. This was sometime in the 1890s. So people did worry about cultures and how to do therapy across cultures and languages for more than 100 years. And I think we need to learn. We should be aware of this complex and complicated history of, after all of us who are talking now in the conference will talk in English. And all the books we would have read would be in English.
Yeah.
Although we are ostensibly in Indian culture, but I don't remember reading a single book in Indian language about psychiatry or psychotherapy. So there we are.
Okay.
Do the organizers? There doesn't be a clock at the bottom anywhere. So how are we for time? I think
yes, we've exceeded time, sir. Yeah. So I think we'll move on to the next session.
Thank you.
Concluding remarks.
All right. Thank you, Dr. Jain and Dr. Jessica. It was good being a part of the first session. Over to Dr. Jain now. Thank you. Okay. We will move on with our next session. We're not going to have our break right now because we've gone slightly over time. I'd just like to remind everyone that we will try to stick to time as far as possible. So for the 1 hour sessions, since we have 2 speakers, we will be having about 20 minutes each for each of the speakers and a further 20 minutes for questions. So that would constitute the 1 hour. And so we'll move on to our next session, which is to do with personality disorders as well as temperamental disorders, externalizing spectrum disorders. I will hand it over to Dr. Suhas, who is going to be the moderator for the session.
Thank you, Dr. Jayan. It's my honor to introduce Professor Matthew Verghese, who is the head of geriatric psychiatry and family psychiatry at Nimhans, Bangalore. His areas of interest include geriatric psychiatry, individual and family therapy, community psychiatry, and rehabilitation. He has won several awards, including the 3rd Dr. Shiv Gautam Annual Oration of the Indian Association for Geriatric Mental Health, invited international lecture at the 162nd Annual Meeting of the American Psychiatric Association, Indian Psychiatric Society Pune Psychiatrist Association Award for Best Published Papers, and Fogarty Visiting Fellowship at Alzheimer's Disease Research Center, USA, Fulbright Alumni Exchange Mini Fellowship in Geriatric Psychiatry, USA. Over to you, sir.
You have to introduce speakers. Yeah, so I'm happy to introduce the first speaker, my colleague and friend, Dr. Vivek Menegal. Vivek Menegal is the professor of psychiatry at Nimhans, and he is a member of the Center for Addiction Medicine. He's been interested all his life in developmental behavior and how early childhood influences relate to how psychopathology and mental illness occurs now. In recent years, he's been the head of a very large cohort study from India called the C-Veda, which is linked to the Imagine and other studies all over the world. So without much ado, I would invite Vivek to start his talk.
Sorry, having a little bit of problems with the buttons there. I'd really like to start off giving a little background to myself. I'm a psychiatrist by training, and my work has been in the area of addiction. But as Matthew said, that for a long time now, I've been looking into the developmental origins of the trajectories of brain development, of the vulnerability to addictions, externalizing disorders, etc. And this, in a way, has informed the work that I do. It has also informed, in a way, the therapy that I do. So, at one level, what has happened with the neurobiological work is that the more we learn about neurobiology, the more we keep getting dragged into looking at the social dynamics which seem to affect or to impact the developmental origins of brain trajectories, of psychological abilities, etc. So what I'll try and do, I'm trying to go up to my slides. I don't know whether the full slide can be seen.
No, sir. You need to share your slides, sir.
Yeah, 1 minute. Share.
Yes, sir, your slides are on.
Yeah, okay, great. So, I was actually interested into talking about this topic because I was asked to actually talk about therapy in people with antisocial personality disorder, and I decided that I probably need to take a different tack to reflect on the kind of people that we do see regularly in the clinic. Now, when one talks of antisocial personality disorder, the core concept which is there in people's mind is that of psychopathy. Unfortunately, except for people who work in correctional institutions, etc., people with psychopathy are not people who we see regularly in the clinic. What we instead see are people who have a wide overlap of people with antisocial behaviors, with conduct problems in childhood, with ADHD, attention deficit disorder problems, with a smattering of borderline issues and mood and anxiety problems. And in our context, what we really see are people with all this and a lot of substance use disorder issues. Now, you can look at this, and this has often been seen as conforming to a higher order dimension of the externalizing spectrum of behaviors, where most of these behaviors have one common thing, that they exhibit their distress externally. And one thing that is common to most of these disorders, transdiagnostically across the externalizing spectrum, are problems with executive dysfunction, problems with impulsivity, difficulty in sustaining motivation. These are people who start with a lot of enthusiasm, give up midway. These are people who have problems with negative self-appraisal, poor experiential learning. They have problems with reward deficits, and often these lead them to self-medication with substances, and they have problems with emotional regulation and emotional recognition. Unfortunately, when one looks at most of the constructs of these externalizing symptoms, it's the executive dysfunction which is most often mentioned and talked about. And a lot of the interventions that are there are for executive dysfunction. And very few therapeutic methods really target the emotional regulation and the emotional recognition problems. Apart from these, which are often thought of as internal issues, there are ways of responding that patients have developed, that our clients have developed, that they have learned from developmental experiences. For example, as they grow up, adverse exposure to adverse childhood experiences, difficulties in parenting and attachment, problems in the school environment, learning and problems in achievement, difficulties in peer and trusting relationships, labeling that occurs when they are not able to develop adaptive coping strategies, repeated failures to conform, etc., give rise to a set of characterological problems, which you can call them schemas. Some theoreticians have called them cognitive distortions, etc. So net-net, what one sees in this group of people is two sets of problems. One set of problems are these psychological capacities or capabilities or lack of capabilities in dealing with day-to-day functioning and dealing with the external and internal world, as well as these learned schemas which have been learned as they have engaged with the world. Now, one of the things that is emerging from neuroscience research recently is our understanding that the trajectories of brain development, whether it's brain structure, functional connectivity, etc., these are shaped by dynamic interventions between the heritable genomic information and exposure to environmental influences through the lifetime. I mean, especially during specific, windows, risk windows like childhood, adolescence, early adulthood, etc. And these environmental influences span a wide variety of effects like nutrition, neurotoxins, psychosocial stressors, etc. And this interaction seems to be mediated by epigenetic and other mechanisms like stress, inflammation, etc. But the most important thing to remember here is that these developmental trajectories also underlie the acquisition of psychological abilities that the individual uses to engage with his or her external and internal world. And they are at one level responsible for broad, pervasive patterns which affect his or her sense of self and relationships with other people, which get elaborated throughout the lifetime. And they have been variously labeled as temperament, personality, schemas, etc. They also incorporate things like learned skills to deal with daily challenges. What we're also learning is that these repeated engagements with the world in turn make neuroplastic changes, giving rise to learning, habits, addictions, etc. So what at one time was fairly discrete, that you had innate psychological abilities and you had acquired or learned responses, seems to be closing in, and there is a very, very wide overlap between these two. However, when it comes to looking at our individual clients, one of the things that seems to pop out is that most clients come looking for help because they are in a stuck state. The client is looking for solutions because he or she can't escape from, painful emotional states. These are, because the person has developed maladaptive strategies or has automatic emotional responses to things that happen or to persons that he or she faces. For the client, there seems to be no escape from these self-defeating schema. And multiple attempts at control have met with rapid return to previous levels of distress, to previous levels of being. And the client falls back to maladaptive coping mechanisms which were probably adaptive to begin with, for example, substance use, but over time has become maladaptive. And here, the issue of personality disorder is a major issue, because patients or parents of patients report that the diagnosis of personality disorder is the ultimate character slur, and it's the ultimate realization of every worst fear that one had about themselves, and it also reinforces messages from abusers, etc. It's also a trap for the therapist or the healer, because the therapist or the healer becomes trapped by this diagnosis of the personality disorder. And if you look at any definition of any personality disorder, you will find these are concrete, pejorative, judgmental, and they evoke therapeutic nihilism. And it is true that clinicians also see treatment outcome less optimistically if someone has a diagnosis of, say, antisocial personality disorder or borderline personality disorder. I think we should not be too hard on ourselves. This has historically been the case with most conditions which have been difficult to treat. And this historically has been the stance which has been applied earlier to leprosy, to tuberculosis, to insanity, and most recently to substance use disorders. So one of the first things that we try and do in our clinic is to reframe. And reframe based on the learnings that I talked about. So what we do in our clinic is that we take executive function, problems in executive function, problems in emotional recognition and emotional regulation as the central transdiagnostic focus. That this is the reason why other things are happening. And in this, we use ADHD. We consciously use ADHD as the central motive instead. And one of the reasons is that for all concerned, ADHD seems to be a much more hopeful formulation with possible solutions than is a diagnosis of antisocial personality disorder. And then what we try and do in the reformulation or the reframing with the client and the parents, especially in cases of most of our younger patients, is to relate academic failures, relationship failures, deliberate self-harm as consequences or coping strategies consequent to the problems of the externalizing diathesis. Similarly, for our clients with substance use disorders start off as a compensatory mechanism, because it is fairly well known that all substance abuse through the reward pathway actually not just increase intoxication, but also increase improve executive functioning. And once one starts using this regularly, further neuroadaptation causes long-lasting habits leading to addictions. So what one also sees when one does that is that others' responses, responses of parents, responses of friends are understandable in the context of this set of core difficulties. And this allows parental buy-in. This allows the client to buy in, because the client is looking at the client who's come in thinking that he's a bad person, who's been labeled as an addict, a bad person, etc., suddenly starts looking at a different explanatory model. So what this reframing does, and this has become a very major part of what we do in the clinic, it provides an alternate explanatory model and perhaps a possibility for change. In a way, it reduces stigma and guilt, but doesn't remove responsibility to act on it. And for the therapist, it suggests a framework for interventions and hopefully reduces therapeutic nihilism. So the therapeutic strategy that we follow with this set of clients, and I must be very clear that what I'm describing to you is what we do in practice, and not really something which has been validated by a whole lot of evidence, which is probably the next step that we need to do. So what we do is a judicious combination of pharmacotherapy and psychotherapy. Pharmacotherapy can include stimulants, non-stimulants, mood stabilizers, supplements as required. We make use of an exercise regime, yoga, physical treatments again as required. But the psychotherapeutic focus is on treating a vulnerability, focusing on the executive function behavior deficits using CBT, DBT techniques. We also focus on emotional regulation and emotional recognition using techniques which are borrowed from dialectical behavior therapy. And to a certain extent, we try also to address pervasive, long-standing schemas or cognitive distortions, which most people have developed by the time they come to us, because they've gone through a long period of interfacing with the world, which has been, has treated them difficultly. And, we have taken or borrowed from schema therapy and CBT. The second thing that we do, remember that most of our clients are substance use, have substance use, is that we address the neuroadaptation which has led to addictive behaviors. And here we are led by motivation enhancement principles and relapse prevention therapy, which is principally uses cognitive behavior therapy models. One of the difficulties that we face is that it is very difficult in this population to be protocol-based, and one needs to be more flexible because most of our clients have difficulties managing their emotions and responses, so it makes it very difficult to focus on just one issue in each session. And a lot of our clients have crises which require management off schedule and sometimes off hours as well.
Vivek, to tell you that you've completed 15 minutes.
Yeah. So, okay. So can I have 2 or 3 more slides?
You have 20 minutes. You have another 5 minutes.
Okay, thank you. There's also a need to develop a long-term, deep and genuine therapeutic alliance with the client. So we try and encourage a sustained relationship with a positive figure. And this particular therapeutic stance that I'm talking about is best achieved with a multidisciplinary team, a psychologist, a psychiatrist, and possibly a case manager, because it allows different skills to be brought in, and it also allows support and feedback within the team, which is very necessary when one is dealing with clients who have this kind of array of issues. So, in a way, our therapeutic stance is borrowed from motivational interviewing. And one of the things that we have picked up from motivational interviewing is the concept of ambivalence. What appears to be resistance in clients is often imbalance and confusion about change. And clients seem to be stuck between a simultaneous attraction and resistance to change. And here we use decisional balance to contrast pros and cons. The other therapeutic stance that we have is borrowed from dialectical behavior therapy. And I'll just quickly go because there's not too much time, that these DBT assumptions are very, very attractive, especially for people who are dealing with the externalizing disorder spectrum, that clients are doing or trying their best. Clients want to get better. They want to experience less suffering and more happiness in their lives. They need to work harder and be more motivated to make changes in their lives. They need to learn how to act skillfully in all areas of their lives. And they cannot fail in psychotherapy because it cannot be attributed to the lack of progress. I mean, the lack of progress cannot be attributed to resistance. It wasn't the client who failed, but the therapy that failed the client. So I'll quickly run through the procedures that we use. We try and teach skills related to executive function difficulties using cognitive behavior therapy techniques. We try and reduce emotional reactivity using some of the DBT techniques which we have borrowed. We focus on distress tolerance skills. We try and increase positive emotions. And one of the things that we try and encourage clients to do is to look for something which is very, very interesting or very, very important in their lives. We encourage them to find their own Mount Everest and to climb it. In summary, what I've actually tried to talk about is the use of a transdiagnostic model of the externalizing dimension, which overlaps a number of categorical diagnostic formulations. I've tried to focus on how we use reframing to aid understanding and acceptance, provide a scaffolding for testing interventions, and a theory for testing later on. I've also very quickly run over a describing a transdiagnostic team-based multimodal approach to treatment using elements from different sources, which are currently in practice because we've been using this for about 10 years, but yet to be subjected to rigorous academic scrutiny. And this brings me back to what Dr. Yackley was talking about, the fact that there's not too much research done in this field. And this is definitely a lacuna which needs to be filled in the future. Thank you very much. I'll stop there.
Perfect. Vivek, you've finished in 20 minutes. Thank you very much. I'll now call upon Dr. Jessica Yackley, and she's already been introduced, so I don't have to introduce her. Jessica, when your slides are ready, you can go on. And we'll take the questions right at the end. So people put their questions in the chat.
It says I can't share screen.
I've stopped sharing, so you can go ahead, Jessica.
Okay, sorry, let me just.
Yeah, we can see you, Jessica.
Okay, you can see the slides, can you?
Yeah. Yes, we can see you too.
Okay, good. Well, thank you very much. I thought Dr. Benegal's talk just now was extremely interesting to me because my area of specialty is antisocial personality disorder. And I now wish I was giving a talk about that because I think some of what you said, Dr. Benegal, was fit in so well with my approach or can be integrated. And as I've said, I am a psychoanalyst and psychoanalytic therapist, so I come from there, but I certainly try and integrate other therapeutic approaches. So I'm going to be talking about therapeutic approaches to personality disorder in general, and I just want to give a bit of historical context, which Dr. Benegal has also given. But certainly in the UK, up until about 20 years ago, psychiatrists were really not interested in personality disorder. They wanted to treat people with mental illnesses like schizophrenia, anxiety, depression, but they thought either personality disorder was not treatable, or it wasn't really, a problem, or psychologists would treat it, and it was really a not very good situation. However, there was a very influential document in 2003 from the Department of Health called Personality Disorder, No Longer a Diagnosis of Exclusion. And this really drew attention to these individuals who suffer from these problematic personality traits and personality disorders, how they're being rejected by services, they're not getting the treatment that they need, and that there are effective treatments. There were, of course, people, for a long period of time who have been interested in treating people with personality disorder, but mostly from a classic psychoanalytic psychotherapy perspective. But it's now recognized that, at least in some cases, long-term psychoanalytic psychotherapy can be ineffective or even iatrogenic. And, for example, the more severe cases can develop a transference psychosis. So that's, a sort of very fixed therapeutic situation that they get into with the therapist that they can't get out to, or severe regression. So there's been a move in the last 20 years towards the development of less intensive, shorter outpatient therapies, which are empirically based. That is, that they're based on robust empirical evidence, specific, particularly randomized controlled trials. Now, because of shortage of time, I'm not going to, I think you all know what personality disorders are. I'm just going to say, again, fitting in with what Dr. Benegal has said, is that the etiology is multifactorial. There are no simple causal relationships, and there is, very good evidence for heritability, maybe up to 50%, but also good evidence, for, and we sort of know this for a long time, but there's more empirical evidence now, for the role of early adverse childhood experiences such as trauma and abuse, and how these interact with each other, as Dr. Benegal has said, in complex ways. I just very briefly, I thought it was interesting. I'm more familiar with the prevalence in America and Western Europe, but there was one international study that I came across that said that across 5 continents, that said that this is in the general population, that said found the prevalence to be 6.1%. More common in men than women. I actually thought it was the other way around. Higher prevalence in urban areas than rural areas. Be interesting to know what that was. And prevalence increases, as you would expect, in health setting as you go psychiatric. And then in my field, in the criminal justice system, studies have shown that up to 70% of inmates in prisons have personality disorder, mostly antisocial personality disorder. Comorbidity, just very briefly, but you need to be aware of it, and it again fits in very much what Dr. Benegal was saying. High comorbidity with other mental illnesses, smoking, alcohol, drug misuse. Physical health often gets forgotten. When comorbidities, its outcome is poorer, reduced life expectancy, not just from increased rates of self-harm and suicide and violence to others, but also poor physical health. And there was a recent study done by one of my colleagues which showed that people with personality disorder die something like 7 or 8 years earlier than the people without personality disorder, which is really significant. And that comes into therapeutic approaches. And I'm sorry I'm talking rather fast, but I want to get this done in the allocated time. Prognosis is much better than when we thought 20, 30 years ago. Interestingly enough, personality traits continue to develop throughout the lifetime until at least the age of 60, maybe beyond that. And we also have to be aware that problems can develop later on in life than late adolescence. So, the diagnosis is meant to be from late adolescence, but they can develop earlier and later. And also, it tends to get better, untreated, problematic personality traits, but it can get worse in some cases. Now, coming on to specific psychotherapies, as I say, the traditional therapies in the last 20 years have been adapted and empirically tested in randomized controlled trials to indicate that they're effective for personality disorder. And they've mostly been done for borderline personality disorder. So if you think of the major traditional schools of psychotherapy, and then what have they been translated into? So this is a bit of a generalization, but behavior therapy, you could say, has become dialectical or adapted for PD into dialectical behavioral therapy, CBT into schema-focused therapy, psychoanalytic psychotherapy into transference-focused therapy. That's therapy developed by Otto Kernberg and his colleagues in the United States, psychodynamic into mentalization-based treatment, and integrative into cognitive and analytic therapy. Now, there are many more adapted therapies, but I just thought that's sort of interesting in showing how those main ones have developed. Thinking in more general about the treatment of people with personality disorder involves several stages, which I'm going to go through rather rapidly. So obviously we have to do an assessment, which personality disorders, there's often, they have several, which is, demonstrates limitations of our diagnostic categories and systems. As I've said, very important to look at comorbid conditions and how that would fit in with your treatment plan. And risk assessment is also important, particularly for self-harm, suicide, but also violence towards others, particularly in the antisocial PD people. Setting, that's important. There's been a move away, at least in the UK, from inpatient settings towards outpatient day centres. Therapeutic communities are becoming more popular again, particularly in the criminal justice system in the UK. And as I've said, that more services are developing specialist personality disorder services, but this is at the expense of more specialised psychotherapy services for depression and patients with depression and anxiety and general relationship problems. You need to think about other treatments, so not just your specific psychotherapy, but how does that fit in with other social aspects of treatment and medication? Is your therapy going to be delivered in individual or group? And then the supervision is absolutely essential. I'll come to that. And I'll also talk about countertransference. Treatment of, so I'm going to go to the specific treatments. Again, I'll whiz through this. So cluster A and cluster C. Cluster A, schizoid, schizotypal, and paranoid. Cluster C, avoidant, dependent, obsessive. Basically, the message is that there haven't been really any good trials on these specific personality disorders. Most of the research and interest has been on borderline personality disorder, to a lesser extent on antisocial, and actually also narcissistic. And I think, again, this demonstrates limitations of sort of separating out these different personality disorders. So I'm going to come to the cluster B, and particularly focusing on borderline personality disorder. As I've said, there's been the development of these specific therapeutic modalities, but it's not possible for all personality disorder patients to have these therapies. They're not available. There aren't enough therapists who can deliver them. Therapists need intensive training, so that's relatively expensive. There's too many personality disorder patients in mental health services in general. And also a limitation is that although in general they've improved symptomatic outcomes, they've failed significantly to improve social functioning. So this has led to thinking about a more generalist model for the treatment of borderline personality disorder. And this is, so this came out of, or one of the areas this came out of, was that randomized controlled trials, which had been designed to show the efficacy of a specific treatment, for example, mentalization-based treatment, the control within those treatments, so I'm thinking particularly of a randomized controlled trial for MBT, the control was what was called structured clinical management, which was essentially treatment as usual, but it was more structured in that the psychiatrists had a little bit more training in what was personality disorder, but it wasn't meant to be a specific treatment. And to people's surprise, structured clinical management did as well as the specific therapy. So this has led to the sort of manualization, if you like, of a more generalist approach to the treatment of personality disorders, which is designed for use by all clinicians, including those who are not personality disorder specialists. And ideally, we feel that this should be routinely incorporated into the basic training of all psychiatrists and other clinicians, such as psychologists, who are responsible for treating patients with borderline personality disorder. And I mentioned earlier that the curricula are all being revised, and I've been involved in promoting or making sure that training for personality disorder is embedded within these curricula, for psychiatry. This is, sorry, just can't see my slide. So this is the, sorry, I'm just trying to get my slide. Sorry about this, let me just check something. So Anthony Bateman, who developed MBT, have proposed the following characteristics for a generalist approach to treating borderline personality disorder. So this is that that treatment providers should have previous experience of treating people with personality disorder. That in general it should be supportive, and some therapies, like more psychoanalytic, have not always been predominantly supportive. They've sort of, sometimes focused on more negative attributes. But the evidence has shown that supportive interventions are very important. Managing life situations is important, not as in some therapies focusing on in-therapy interactions, and for psychodynamic that would include, we'd talk about transference. They should be non-intensive. These patients are challenging, so it will be expected that there will be interruptions in the therapy, and consistent regular appointments are therefore optional. And in other words, one shouldn't be too strict about things. So if they don't turn up to appointments, you shouldn't immediately discharge them. That is going to be the nature of their presentation. Medication is essential in some of these individuals, and they should be integrated. Also, group and family interventions are encouraged where necessary. Sorry, why is that not going? Sorry, something's stuck here with my... So I'm very sorry about this. I can't understand what's going on.
Jessica, apparently you can click the arrow on the bottom left-hand corner.
My arrow is not working either. I think my computer is frozen. I can't believe this. Sorry, can you still hear me? Hello?
We can hear you and we can see the slide.
Okay, you can
Your
see
slides
I can't get into the next slide.
Your slides are not moving forward, is that it?
Yes, I can't get onto the next slide. I think it's my...
Stop sharing and then...
Yeah, stop.
You stop, Jessica, just stop sharing and then share again. Try that.
I think my computer has frozen because I can't actually... I think I might just have to continue without the...
Stop her from sharing, no? Can you stop her from sharing? Okay, we'll stop you from sharing.
Stop me from sharing. I may have to just come out of my...
Yeah, okay. Now get back to sharing again.
Okay.
Now try to share again.
Okay.
Can you see your slides now? Are your slides moving?
Yes, I just have to get back onto the... No,
Yeah.
sorry, that's the right one. No. Sorry, I'm just... Sorry, what can you see on the screen?
Your Word file is what we are seeing.
Okay, is my PowerPoint on the screen now?
No, we are seeing a Word file. Just
sorry, can you stop share screening again? Okay.
You see different options on your share screen and you click on the PowerPoint.
Yeah, I'm just trying to find the PowerPoint has... okay. Right. Okay.
Perfect.
It's still not moving.
There's an arrow on
An arrow, yeah.
All right, find it. Okay, sorry. Okay, I'm really sorry about this. Okay, so these are just very briefly recommendations. I think I will skip that actually. Basically, just saying medication is still important to think about. I did more want to talk about actually from a psychotherapeutic viewpoint the meaning of medication. So just think about why patients might consciously or unconsciously want medication. So obviously for symptom relief, but also they may be secretly using illicit substances, including some medications like morphine-containing things, to what they would think was medicating their unsettled, know about it. Others may be suspicious of all medication and so be quite resistant to taking it, even though you think it might be effective. Also, they might be resistant because they think that it might signify that they are more ill, and somehow having psychotherapy, they can sort of think they're not that ill if they're just having psychotherapy. Some psychotherapists, I'm afraid, still are against the use of medication because they think that it dilutes their therapy and that they feel that that you need a sort of pure therapy. So some patients, I think maybe rightly so in some cases, would like medication, but the therapist isn't willing to offer. At the same time, medication might become an intrusion into the therapeutic work, and it really, it might do. And particularly when a patient who has a tendency to splitting, like some borderline personality disorder patients, who might attribute all the improvement to the medication rather than to the therapist or the therapy. Very briefly, antisocial personality disorder, which I'm involved in. There have been very few trials, so there isn't actually there isn't a psychotherapy that's been shown to be effective in any robust randomized controlled trial, and I'm involved in a RCT for a treatment for antisocial personality disorder, or evaluating mentalization based treatment for offenders in the criminal justice system. So that's ongoing. We've been doing it for the last 5 years, and we're coming to the end of it. They're very difficult to engage in treatment, often drop out, they misuse medication, drug and alcohol abuse. Obviously, they're risk issues. I'm going fast here.
Just to let you know, you have 4 more minutes, please.
Okay, I think I'm going to just miss that one out. Just to say, there are integrative approaches. It's unhelpful that there are all these different psychotherapies, all the ones I've told you about, that all have 3-letter acronyms: MBT, CBT, DBT, and they all pretty much show the same efficacy. So there is a move now to integrate therapies, or have different therapies at different times in the patient pathway in a more integrated way, depending on the stage and severity of the personality disorder at that time. And I just want to finish with the countertransference. So this is my more psychoanalytic part of me coming out. So the countertransference is the thoughts and feelings that the therapist or clinician has towards the patient, which we feel as psychoanalysts are the unconscious communications of the patient that are reflected or projected, if you like, into the therapist's bodily and emotional responses. And awareness, we feel that awareness of the clinician's countertransference is very important in helping understand. I put the offender and the risk that he poses. Sorry, this is obviously taken from my slides on antisocial personality disorder, but patients in general, and can inform your therapeutic interventions and interpretations. And we very much feel that if you don't acknowledge the emotions that you have, which include, some quite negative emotions, such as I've listed here, such as believing that they're not treatable, anxiety or fear, particularly for violent ones, maybe the denying that you're anxious at all, that's maybe more dangerous. You might feel quite guilty or helpless when you feel that you're not doing you're not doing them good, that they're not improving. That may then lead to actual feelings that you're losing your professional identity. You may feel very aggressive towards them. You hate your patients. That's very difficult to sort of admit that, and even more difficult to admit is that you might actually be sexually attracted to patients, and that's very rarely talked about. And what we feel is that inevitably we're going to have emotional reactions, and if you deny those or repress those, they're more likely to come out in unhelpful ways, including boundary violations or being more punitive in your attitude towards them. Or from the patients I deal with, you might assess their risk as more risky than it really is, which means you can lock them up or put them in seclusion. I think I just want to finish on that note, and that the importance of supervision and reflective practice, such as these Barnet groups, where these interactions between the patient and the therapist, thinking about the emotions that are generated, we feel are absolutely essential in managing these, patients who can be really quite challenging. So I'll finish there. Sorry about the interruptions in the talk. Thank you.
Thank you very much, Jessica. You're well in time. You've finished in just about 21 minutes. So I think we have time for some questions. We have few questions up. But before that, I'd like to engage both Vivek and Jessica in a couple of questions that I have. And that is, you spoke earlier on, Jessica, about medical psychotherapy. And do you think that medical psychotherapy, as opposed to CBT or dynamic therapy, lends itself to a more biopsychosocial approach, especially when looking at personality disorders and drug and alcohol substance abusers? You think medical psychotherapy would be more akin to a more integrative approach?
Absolutely, and I think that's one of the things that we have to highlight in terms of our extra added value, is that we do know about the body. We're doctors, and that's where we come from, and of course the body and the mind are completely connected and integrated, and therefore I agree. I think we do take a more integrative approach. So whilst I think we absolutely have to be aware of the developments in psychological treatments, linking up with our colleagues from other disciplines, we also very much have to be aware of the body, of medications, of development within medications, and integrating that, and not just from the treatment point of view, but also from the neuroscience, which Dr. Benegal was was talking about. I think we very much need to be au fait with that as well in our treatment. So yeah, thank you for highlighting that.
Yeah, I was quite interested to see Vivek's talk about reframing, though reframing comes from a different systemic sort of strategic perspective. And I think one of the questions is also about how you could use ADHD as reframing and how you can use probably a biological model to tell them that, this is what is wrong with you, and tell the family that this is what is wrong with them. So how does reframing, how do you do that? How does that fit into the therapeutic process?
One of the things, I presume this is to me.
Yes, absolutely.
Yeah, so one of the things, like I noted, that does happen in therapy is that both the client and the therapist get stuck with the diagnosis. And the diagnosis of most personality disorders, especially antisocial personality disorder or borderline, has got such a lot of pejorative value that most people get stuck in either believing that nothing will happen, nobody will go forward, or the therapist himself or herself becomes so much more judgmental and full of therapeutic nihilism. And what reframing helps to do is to provide a different set of explanatory models to work with. And this is something which, again, we have borrowed not just from the systemic perspective, but also from the motivational enhancement therapy perspective, where we use what we've learned from, as you said, from neurobiology, about the common underlying deficits which underlie all these disorders. And the reason why I said that it's easier to use ADHD as the explanatory model, not that it strictly is ADHD or that ADHD really explains everything. But in people's minds and in the minds of clinicians, ADHD seems to be a construct which has solution, which has which explains a lot of things that happen or have happened in their lives. And for clinicians, it's a construct where there is some hope, there is some therapeutic value. The second thing is, of course, that we are now discovering from research that a lot of transdiagnostic interventions, which Dr. Yakli was also talking about, are as good in a whole host of different illnesses, and so common interventions, transdiagnostic interventions, are very, very useful.
Yeah, so I think both of you spoke about multiple methods, and one of the things that I think in therapeutic situations we find interesting is that, especially when you have difficult problems like substance abuse or personality disorders, where we ourselves face a lot of nihilism in treatment, is to look at things in a very systemic perspective, look at the whole system and see how things are maintaining factors. And so both of you did not, you probably didn't have much time, but you talked about the family into this whole issue of personality disorders and addiction. And so I'm aware that if you bring the family context in, trials have shown that if you bring the family context in, there is much better outcome as opposed to individual work itself. So do either of you want to comment on that?
Well, certainly I think with antisocial personality disorder, that the earlier the intervention, the better, and that the nice guidelines that we use for treatment is, have shown or recommend that family therapy, with these children with conduct disorder, more, likely to go on to develop antisocial personality disorder, is recommended, and similarly with adolescents. But I just want to sort of, maybe it's not quite answering directly, but thinking about a more systemic approach in terms of the staff. So all the staff are involved in treating. And I think I've mentioned something, about supervision. So you shouldn't be treating these patients in isolation, but also you should just be thinking about the staff group and the teams and the institution that is treating the individual, and how pathological dynamics within the institution can impact on the treatment. So we at the Portman Clinic do a lot of reflective practice. So we go into medium secure units and prisons, and we talk about how these patients or offenders, again, emotionally impact on the staff, and how that creates tensions, not just between the staff and the staff and the offender or the patient, but also within the staff, so that, in other words, the whole pathology of the patient can get reflected in the pathology of the staff and of the whole institution. You get these toxic cultures. So we're thinking about, a sort of system, if you like, institutional treatment, not just treating the patient, but treating the institution that treats the patient.
Right.
I would take a slightly different tack here, and one of the things that has struck me the most when we've read about psychotherapy, when we've tried to understand psychotherapeutic models, is the basic difference, the basic social difference that we have in India and in cultures like ours, where unlike in the West, where individual autonomy is what you're striving for. So unfortunately, what happens here is that you cannot treat an individual without treating the family. The family is so enmeshed, and although in a Western context, the enmeshment is often seen as a nuisance or a part of the pathology, in an Indian context, you cannot escape, but also treat the family as well. And this is more so in this whole set of externalizing disorders, including ADHD or the other things like borderline, etc., where the family and other significant others are very much part and parcel of the dynamics that are happening. And it is impossible in the Indian context to treat the person and to respect that person's individual autonomy.
Thanks, Vivek. There's one comment and a question here, and that is, a therapeutic alliance seems to be a good idea for a more holistic approach to treatment, but is there a way to account for the differences in schools of thought in this alliance? Because there seems to be quite the divide between CBT approach and the psychoanalytical approach in psychotherapy. Either of you want to...
Yeah, the strength of the therapeutic alliance has been shown to be the strongest predictor of the efficacy of the therapy, regardless of what the model is. But then I guess what you're saying is, well, are there differences in the therapeutic? What is the therapeutic alliance? What does that mean? And how do you define that? And I think in psychoanalytic psychotherapy, we would be aware of the unconscious determinants, and we would also, it's the focus of the therapy. So what we believe is the main driver of change is the relationship that develops between the patient and the therapist, particularly those unconscious factors. And that's what we focus on in the therapy. Whereas other treatments, I think they pay attention to it, but it's not the focus of the therapy. And I think, again, there have been a lot of trials and process trials and trying to look at what elements of therapy and how they contribute to outcome. There's a lot of research going on, but really with not any definitive answers, I think. But I think what has been shown actually is that, as I say, the more positive treatment alliance, so really focusing on the positive, which psychotherapy, or certain schools at any rate, don't do that or are wary of doing that. But I think that has been shown to be effective. So I'm personally, as a therapist, I have moved more to emphasizing, or at least starting off with positive transference rather than negative. If that makes sense.
Right. Okay, I think we are getting towards the end of time, so but I still have time for one question to both of you, and that's a question from one of the participants who says, "What is the neural mechanism for the effectiveness of psychotherapy?" And I'm aware that there are
Dr. Bennigan. Dr. Bennigan, not that one.
I really can't go with that, but I can't. I see the dichotomy between psychotherapy and pharmacotherapy is something that people keep talking about, and I can't but resist quoting Deng Xiaoping, who said that black cat, white cat doesn't matter as long as it catches mice.
Right. Okay, on that note, I think thank you very much, both of you, Vivek and Jessica. I think this is a good dialogue, and it talks about how Tavistock and Nimhans should really talk, and we should do some collaborative work, because there's a lot of interesting work that is going on back and forth, and we have not done any collaborations really with Tavistock. So hope for that in the future. Thank you, both of you. Back to Suhas.
Okay. Matthew, Professor Vivek, and Professor Jessica. It was a very, very entertaining and enlightening session. And I think we'll go ahead straight into our next session for the day, which is going to focus on trauma. No, we're not going to have a tea break. A virtual tea break. I think everyone can probably have some tea wherever they are sitting. So I will hand it over to our moderator for today's session to introduce our chairperson as well as the speakers. So Dr. Shruti is Senior Resident at the Department of Psychiatry. Over to you, Shruti.
Thank you, sir. So the chair for the session today is Dr. Dinesh Bugra. Dr. Dinesh Bugra is an Emeritus Professor of Mental Health and Cultural Diversity at the Institute of Psychiatry, Psychology and Neuroscience, King's College, London. He has held various prestigious positions like the President of World Psychiatric Association, President of Royal College of Physicians, and many others. He has authored and co-authored over 400 scientific papers, chapters in over 30 books. He has also been a recipient of numerous awards, and he continues to champion the cause of people with mental illness. So the speakers for today are Dr. Shekhar Seshadri and Dr. Joanne Stubley. I hand over the session to Dr. Dinesh to introduce our speakers and go ahead with the session. Okay. Dr. Shekhar Seshadri is a senior professor at the Department of Child and Adolescent Psychiatry in Nimhans, Bangalore. Besides working with child and adolescent mental health, including developmental disabilities, he's actively involved in the areas of gender and sexualities, violence, trauma and abuse, children in difficult circumstances, juvenile justice, experiential methodologies, school programs, teacher training in life skills education, community and school mental health programs, forum theatre, and qualitative research. Our second speaker, Dr. Joanne Stubley. She's a consultant medical psychotherapist, psychoanalyst at the Tavistock and Portman NHS Trust. Her areas of interest include trauma, historical child sexual abuse, complex trauma, and refugees. I hand over the session to Dr. Dinesh Bugra. You can go ahead with the session.
It's possible that Dr. Bugra is having some connectivity issues, so I'll request Dr. Shekhar to start off with the session, and hopefully Dr. Dinesh will join in. Over to you, Dr. Shekhar. Sorry, you have to unmute your mic, sir.
You need to unmute yourself.
My deepest apologies for the tech error, some configuration issues. Thank you very much for this invitation. I'll be trying to relate psychotherapy across epochs and methods, which is the larger theme of this two-day meeting, to internalizations as the focus of healing-centered engagement in child sexual abuse therapy. To begin with, let me wish everyone from Tavistock, give them my heartiest congratulations on completing 100 years. Interestingly, the Tavistock Clinic saw its first patient, a child, on 27th of September in 1920. And Hugh Crichton Miller's aim was actually to provide civilians with the kind of treatments that he and other doctors had developed while working with shell-shocked soldiers during the First World War. So trauma was already an important part of the agenda of Tavistock. So for everybody from Tavistock, heartiest congratulations on completing 100 years. Now, the whole issue of psychotherapy across epochs, and if you look at Tavistock itself and look at child development coming to the fore, and all these illustrious names that have been associated with Tavistock, with John Bowlby and his concept of attachment to Martha Harris with the focus on child development, and John Bing Hall, family therapy, Alexis Brooke on community-based approaches, and Joan Hutton, who spoke about brief therapy. So you can see that across epochs, the various approaches to psychotherapy kind of change in Tavistock itself. And in 2005, the Tavistock and Portman, the main provider of child and adolescent mental health services for Camden, was set up. And the multi-agency liaison teams, which actually use a systemic approach to emotional well-being services for young children, linked up with the Anna Freud Center to develop a whole system approach. The Thrive model, this was launched in 2014. And in 2017, the Charing Cross Gender Identity Clinic joined the Tavistock and Portman. And in 2017, the trauma unit provided support to a number of frontline services after the Grenfell fire. And Joanne Stubley, who's going to speak after me, leads the trauma unit. And the unit broadened its scope and developed expertise in addressing complex and developmental trauma, working with asylum seekers, refugees, veterans, and survivors of childhood abuse. So this is the history of Tavistock and Portman. But let's look a bit at the pioneers of Indian psychiatry. Murli, in his presentation to set the ball rolling today, did take us to some history, but I'd like to focus on one name, N.C. Surya, and Dr. Naren Vig writes about him. I became aware of Surya in 1961 while preparing for my DPM examination in London. I saw his name in the acknowledgement section of the famous textbook of clinical psychiatry by Mayer, Gross, Slater, and Roth. It was not uncommon in those days to find an Indian being acknowledged by English authors. I was naturally curious to know more about this person, and I had my first meeting with him in '64 in Bangalore. And he presented a brilliant paper on the basic concepts of psychotherapy in the Indian setting. Now, Surya went, in '52, he went to the UK and he worked in the Institute of Psychiatry in London, and then in Leeds, where he did his DPM in 1955. And this is what Surya says. In the use of the word dependency in relationship, we can already discern the language distortion and interpretation distortion he spoke of. And you'll recall that both Murli and Sanjeev, who was chairing the session, spoke about this whole notion of culture and Western value judgment. And Surya at that point of time said that this is unwittingly thrust on people, and there is no equivalent word of conveying the same value of judgment. And one speaks of bandha or sambandha or bandhavya, which means bond, bondship, kinship, and not of dependency. And it would be hazardous to import this word dependency into the Indian psychotherapeutic scene. But going forward, he also spoke about personal autonomy, and he says, of course, I owe the word autonomy to Ivan Illich. And he has done great service in illustrating the social roots of the systematic erosion of autonomy in health that has taken place over many years. Later, Dr. Ramachandra Rao, who headed the Department of Psychology in Nimhans, he spoke about the conception of stress in Indian thought. And following on these two major names, the psychotherapy training program, as Murli pointed out, started in 1983 under the guidance of Dr. Shyam Sundar. It began mainly in brief dynamic therapy, but progressed to training in different schools of therapy in accordance with the evolution of the field of psychotherapy. At this point of time, what I want to emphasize is context matters where trauma is concerned. And if you look at the context, natural disasters, man-made disasters, displacement, armed conflict, complex humanitarian emergencies, refugee status with Joe Stubley is so deeply engaged with, trafficking, loss, death and dying, accidents, disfigurement, loss of body parts, terminal illness, assault and violence, but two critical issues. Adverse childhood experiences of its sexual abuse is one, and its intrinsic and sometimes deep relationship with suicidality and suicidal behaviors. Firestone speaks about identification of the suicidal individual in terms of what he calls as voice statements. And he speaks about increasing levels of suicidal intention, where thoughts that lead to low self-esteem and inwardness, which is self-defeating thoughts. As you can see here, self-deprecating thoughts of everyday life, such as you're incompetent or you're not.
Numbers.
Could you please mute your mic?
803.
Mahentesh, thank you very much. Two self-content and vicious self-abusive thoughts, which is, you idiot, you don't deserve anything, you're worthless. Thoughts that support the cycle of addiction, such as it's okay to do drugs, you'll be more relaxed, go ahead, have a drink, you deserve it. To thoughts that lead to suicide and self-annihilating thoughts. Hopelessness, see how bad you made your family feel. To injunctions to inflict self-harm. Why don't you just shove your hand under a power saw? To injunctions to carry out suicide plans. You've thought about this long enough, just get it over with. It's the only way out. Now, any combination of these voice attacks can lead to serious suicidal intents, particularly in the context of trauma. This is one way of looking at internalizations. Another way of looking at the internalization model is that the processing of meaning of outer experiences as they relate to the self from which the child responds to or interacts with the outer world, describing the abuse experience, the internalization resulting from it, and the behavior that is a consequence of this internalization. Which means, if abuse is a primary experience, depending on the developmental level, the temperament, the attachment, and earlier internalizations, a child forms an internal view of the world as a result of the abuse. And depending on child characteristics, the abuse status, and family responses, you see behaviors that are manifestations of a distorted interaction with the world as a result of the abuse internalization. And this is how it plays out. It can differ in all abuse experiences, in those that occur with a close relative, and in extreme forms of abuse. If you look at all abuse experiences, the characteristics range from the experience of intrusion to experiences of no protection. If you look at consequences, or such as hopelessness or flashbacks, what's important to keep in mind is the internalization. Because the behavior or a consequence is only an outcome of how a child has processed the basic characteristic of the abuse itself. This is common to all abuse experience, whether it is physical or emotional or sexual. But when it comes to sexual abuse by a close relative, the juxtaposition of closeness and betrayal and the entanglement and the distortion of boundaries gives rise to the kind of internalizations that are depicted here. And when sexual abuse is extreme in nature, either with the attention and the sensual pleasure that it brings, and when you see adult outcomes or later adolescent outcomes of repeated sexualized behaviors, and you look at the kind of internalizations that are likely to take place, or distortions of reality. This is one way of looking at an internalization model to really work on the trauma that occurs in the context of child sexual abuse. David Finkelhor stated it in a different way. My apologies for this slightly busy slide. If you look at the effect, the process, the psychological impact, and the behavioral manifestations of child sexual abuse across the four dynamics that Finkelhor spoke about: traumatic sexualization, stigmatization, betrayal, and powerlessness, often the processes and psychological impact do not figure in conventional forms of therapy because there is so much a preoccupation in reducing trauma symptoms. Many of the psychological impacts and processes that are present in the dynamics that Finkelhor speaks about come from social and cultural factors that actually lead a child to experience an abuse in a certain way. For example, in a gendered context of child sexual abuse, where the embodiment of virtue or honor is related to sexuality, particularly when there is penetrative sexual abuse. This is arising out of the problematic notion, culturally determined, of how virtue and honor are equated with the act of penetration. Stated in another way, the problem with trauma-informed care, as it came from the earlier models of the PTSD model or Finkelhor model, to shifting to what we call as a healing-centered engagement. And you look at how from the 1990s to the 2000s, from resilience to how youth development gained currency, where trauma-informed care encourages support and treatment to the whole person rather than focusing only on treating individual symptoms or behavior. But shifting from trauma-informed care to healing-centered engagement has to address the assumptions that trauma-informed care makes, which is that trauma is an individual experience rather than a collective one. What about the environmental context that caused the harm in the first place? And there is a risk of focusing on the treatment of pathology rather than fostering the possibility of well-being. A healing-centered approach, therefore, is a holistic approach involving culture, spirituality, civic action, and collective healing. It views trauma not simply as an individual, isolated experience, but rather highlights the ways in which trauma and healing are experienced collectively. And the term healing-centered engagement expands how we think about response to trauma and offers much more holistic, it's a much more holistic approach to fostering well-being. There are certain key elements to healing-centered engagement. It addresses trauma with a different set of questions that move beyond what happened to you to what's right for you. In that sense, it is explicitly political rather than clinical. it is not merely about addressing the trauma of an individual child, which of course has to be done, but the child's internalization occur in a culture and a politic which is gendered. Healing-centered engagement is culturally grounded and views healing as the restoration of identity. Even for a child who is trafficked for sex work, the whole systemic intervention of the raid, rescue, repatriation, reintegration, rehabilitation, redressal paradigm, which is raiding the area of sex work, rescuing the child, repatriating the child, reintegrating the child with the family if available and if willing, providing rehabilitation and redressal as present in compensation mechanisms mandated by the law, misses a significant R, which is reclamation of personhood and reclamation of affirmative sexuality. So healing-centered engagement is asset-driven and focuses well-being that we want rather than symptoms that we want to suppress, so that young people can be encouraged to dream and imagine. And an important ingredient in healing-centered engagement is the ability to acknowledge the harm and the injury, but not be defined by it. And finally, psychiatry's myopia, coming back to the point that Sanjeev was making in his closing remarks in the opening session. This appeared in JAMA Psychiatry in September this month. It, of course, is a paper that focuses on severe mental illness. But it speaks about reclaiming the social, the cultural, and the psychological in the psychiatric gaze. And the author quotes Kendler, and Kendler says, "We are stuck with the dappled causal world for psychiatric disorders. We need frameworks for clinical practice that explicitly take into account this reality and see patients' diseases not as we want them to be constituted, but rather as real lived experiences inextricably embedded within social, psychological, and biological contexts." Thank you very much. I see that Dinesh has managed to find his way. Very nice to meet you online, Joanne Stubley, and a pleasure and a privilege to share a platform. Lovely to meet you too, Dinesh.
Thank you very much. Dinesh, you're on mute still. I'll try and start my screen sharing while you're doing that.
Thank you very much, Shekhar, for that lovely talk. I had to sort of wend my way through cyberspace, getting to you. Namaskar, everyone. And it's a great pleasure to have Shekhar and Joe here. Joe has done some fascinating work with refugee children and trauma. So over to you, Joe, and we'll pick up the questions later.
Thank you very much, Dinesh, and also thank you very much, Dr. Seshandri. I am absolutely delighted to be here, and I am already full of thoughts and questions and ideas from what I've heard so far today. I wanted to just sort of start by saying a tiny bit more about myself. As it said on the introduction, I'm a consultant medical psychotherapist and a psychoanalyst. I run the trauma service at the Tavistock Clinic, have done now for almost 20 years. I'm also trained in trauma-focused cognitive behavioural therapy and in EMDR, eye movement desensitisation and reprocessing. I am a clinical trustee for the human rights organisation Freedom from Torture, and I am also a co-chair for a task group at the Royal College of Psychiatrists on historical child sexual abuse. Now, I'm going to be talking today, since my trauma service works with adults, mainly about the presentation in adults from childhood trauma. But I think that what Dr. Seshandri was talking about feels to me very relevant in relation to the kinds of ways we think about our patients. And I just wanted to pick up one little kind of thread that I think has been around so far today. I think that there was in the discussion that Dr. Benegal was talking about in terms of the terrible stigma of personality disorder, that question of what is wrong with you, what's wrong with your personality, is inevitably part of the personality disorder difficulty. I think that what's happened to you is the trauma-informed response, and that can also be difficult. And I think that this notion of the healing-centered engagement, which was being talked about a moment ago, of what's right with you, is something that we would also feel is really important. So I thought I'd start today just by giving a quote from Judith Herman. Now, she says the core experiences of psychological trauma are disempowerment and disconnection from others. And I think that those are important issues in relation to what's been talked about so far. Judith Herman wrote a book in 1992 called Trauma and Recovery, and that was the first time in which the term complex trauma was described. And she was talking about adult survivors of childhood sexual abuse, Vietnam veterans, and survivors of interpersonal violence, domestic violence. And she described a constellation of symptoms. Now, it's taken almost 30 years for this idea to get into psychiatric classificatory systems. We now have coming in the International Classificatory System of Disorders, the European classificatory system, ICD-11, we finally have a diagnosis of complex PTSD, which is going to be something that we can then start really doing much more research on. And what you'll immediately see from this diagnosis is that there is clearly an enormous overlap with borderline personality disorder. The essentials of the diagnosis are symptoms of PTSD, so the re-experiencing, the avoidance, and the hyperarousal, alongside disturbances in self-organisation. And that would include affect dysregulation, negative self-concept, and disturbances in relationships. Now, I would also say in terms of this notion of psychiatry and the diagnostic issues that are brought to bear, that we might want to reconsider using single diagnostic classifications and much more focus on a biopsychosocial formulation, which again, I think links with what the previous, sorry, that's my dog in the background, what the previous speaker was describing. I wanted to put up two of our grandfathers of psychoanalysis, Freud, of course, on the left, and Sandor Ferenczi on the right. And one of the reasons why I bring the pair of them like this is because I think that they can represent a potential split or problem that we can get into. Freud, as many of you will be very aware, began with his idea of the seduction theory before moving on to the development of psychoanalysis, where the focus was on the unconscious and the inner psychic life. Ferenczi challenged this in his classic paper on confusion of tongues by bringing back the importance of external trauma, particularly focusing on childhood sexual abuse. And I think it's really vital that we consider both internal and external, both the inner psychic life and the reality of external factors when we are thinking about our patients. So one of Freud's most helpful descriptions for us of some of the things that can happen came out of his work with shell-shocked veterans. And he described this notion of the repetition compulsion, which I find very helpful in thinking about our traumatized patients. He described how if a person does not remember, and I will talk in a bit more detail about what I mean by remember, he is likely to act out. He produces it not as a memory, but as an action. He repeats it without knowing. of course, that he's repeating. And in the end, we understand this is his way of remembering. And I'll talk a bit more about that in a moment. And just to come back to Sandor Ferenczi, when he wrote Confusion of Tongues, what he was really bringing to the fore was the impact of childhood sexual abuse. And many of the current thinkers in trauma, particularly in the States, the relational psychoanalysts, see Ferenczi as their grandfather of understanding the traumatized defenses. And one thing he focused on was the importance of dissociation. Now, this is Melanie Klein, who we also use a great deal in our thinking about the psychoanalytic understanding of trauma. We use an object relations perspective, and within that, which is part of what Melanie Klein described, we would say that all experiences, no matter what they are experienced as a relationship. Now, I think this is important in terms of one of the things that Dr. Seshandri was talking about earlier when he said that context matters in terms of trauma. Now, I think that's absolutely true, but I also think we have to put alongside that from an object relations perspective, so from the unconscious, in any kind of trauma, it is always experienced as a relationship. Someone or something has done this terrible thing to me, and someone has failed to protect me. And so we get the persecution and the loss of trust. And this is part of what Melanie Klein talked about when she was talking about very powerful early anxieties in what she called the paranoid schizoid position in early life, anxieties of persecution, fragmentation, and annihilation. And she thought that these were responded to by defenses such as splitting, projection, and projective identification. And projective identification is something that we think is particularly important too, because it describes a way in which what is unbearable inside of us is unconsciously in fantasy given to the other, and this has an effect on the other. Now, my predecessor in the unit, Caroline Garland, took many of these ideas and looked at them in relation to adult trauma. And she focused, first of all, on the way in which adult trauma impacts on our symbolic capacity, our ability to be able to think about what has happened. Combining that with these very powerful early anxieties that Melanie Klein described, one gets then an enormous push for action. Thought isn't possible, and action, particularly in what Freud described in the repetition compulsion, is the form of action that often comes out. So that using projective identification as a defense, so engaging in a dyadic way with another, there is a push for repetition of the original traumatic scenario. Now, the other thing that Caroline described is the importance of loss in trauma, and that loss requires mourning. But in order to be able to do that, one has to be able to remember, as Freud was talking about, and remembering requires being able to think about, to have the narrative and the words for the experience, and to effectively feel it. So instead, what we get is the repetition compulsion in the form of the traumatic scenario. So these four positions of different identifications. And within the therapeutic setting, there is a dyadic potential for an enactment within these different identificatory systems. So victim, perpetrator, victim, rescuer, victim, bystander, and the therapist is unconsciously invited by the patient through projective identification to engage in these enactments around these different identifications. And we know about that as therapists through monitoring our countertransference, what we're feeling when we're with the patients. Now, we also make use of Bion's notion of containment, which he talked about in terms of how very small babies are full of these life and death anxieties that Melanie Klein was describing, and they use the defences, such as projective identification, to communicate their distress to the mother. Mother contains this by taking in the projective identification, thinking about it, trying to detoxify it, and being able in that way to contain the baby. Now, we're going to think a bit more about what all of these things mean in terms of childhood trauma, and I wanted to just remind us, this is a best evidence criteria review of the prevalence of childhood trauma, and one can see that it is an extremely common occurrence. Another way to think about that is through the Adverse Childhood Experiences surveys. We're talking about large population surveys done by Felitti and his colleagues, for instance, in 2002, which look at 10 different factors of childhood experience that could be defined as traumatic, and then linked those with both physical and psychological consequences in adults. And it's given us an enormous amount of information about links such as the increased risk of suicide, but also things like the increased risk of traumatic-related disorders in mental health and the increased risk of physical disorders such as diabetes mellitus, cardiac and respiratory disease, and early death. Now, if we think about children having this repeated experience of potentially traumatic nature, we would see that they were having the defense cascade repeatedly activated so that they would be pushed into fight-flight responses, the sympathetic activation, or even into fright responses, going down to flag and faint. And this is when the parasympathetic system is activated and when dissociation is likely to occur. And this is the ordinary physiological response to threat. And what we know from neuroscience is that with repeated activation of this system, there is an impact on the biological functioning, so that one sees that there is a higher activation of the amygdala, which is like our smoke detector in the limbic system, so that people who have been traumatized as children are much more likely to have a full-scale threat response and have chronic hyperactivation, which is part of the description of the hyperarousal symptoms. They also are shown to have, in many cases, smaller hippocampi, and this means that they lose contextualization of the experience, or as Freud would describe, they lose signal anxiety. So every time they are threatened, it is experienced as a full-scale threat. There is also reduced activation of the prefrontal cortex, which impacts on emotional regulation, self-reflection, and empathy. Now, part of, I think, losing the contextualization is what we get described so well by Bessel van der Kolk in his book that many of you, I'm sure, will know, The Body Keeps the Score. He describes how trauma gets held in the body, and this links as well to the loss of symbolic capacity, so that it's held not as memories, not as a narrative, but as images, visceral sensations, and fight-flight reactions. I think that another way of thinking about this that can be very helpful is Stephen Porges, who's an American neurobiologist, talks about the different parts of the autonomic nervous system. And this links with that cascade that I was showing you a moment ago. The yellow part is the sympathetic activation. When we're in danger, we get fight, flight. The red is the life threat. When there is the parasympathetic activation and we get the fright, the freeze response, and that's associated with dissociation. And then the green is what Porges talked about as the social engagement system, which he felt was a part of the parasympathetic nervous system, what he calls the ventral vagus system. And this is how we understand something of the importance of the relationship because physiologically we can help people move out of fight, flight, and freeze by socially engaging with them. Eye contact, facial expression, vocalization can all activate people to be in a calmer, more secure place. Now, we make use of this in this notion of the optimal arousal zone or the window of tolerance. And what we know is that when people have been traumatized, their capacity to be in that central zone where they're not either being hyper-aroused or going into the lower zone, which is the freeze state, when they're in the optimal window of tolerance, they're able to think, engage, have empathy, and to use therapy. And for people who've been traumatized as children, that zone becomes much narrower and they are much more easily pushed into the extremes. And so some of the therapeutic work is around trying to increase the tolerance of being in the optimal arousal zone and being able to stay there for longer and to manage those extreme states. Coming back to that image of the mother and baby co-regulating, having containment together, I think it might be also possible to think about that in terms of biobehavioral synchrony, using, for instance, a neural understanding of mirror neurons. And I want you to think about this both in terms of the mother and baby, but also what we do in the room with our patients. This notion of mirror neurons is really interesting, that if you are watching someone else perform a physical action, your brain will have the same neurons activated as though you were performing the action itself. And this, one might see, is part of the containment and the synchronization. It also links physiologically with heart rates and with hormonal systems, including oxytocin, which we know is our social connection, or if you like, our love hormone. Now, in attachment theory, we can think about this co-regulation, biobehavioral synchrony, in terms of caregiver effective attunement and regulation. And if a child, a baby, has this repeatedly over time of a mother who, in Winnicott's terms, has good enough attunement with this baby, there is a gradual development of a capacity to regulate affects, to be able to be aware of one's own internal bodily state, so to have interoceptive awareness, to gradually develop mentalizing capacity, so to be able to think about one's own inner state and another's. And I think particularly interesting is the development of epistemic trust. Now, this is something that Peter Fonagy talks about, and it's a notion of how important social learning is for all of us. And I think this comes back again to the thread that we've had throughout the day of the importance of social connection. Children learn when they have good, effective attunement and regulation that it's safe to be able to be open to learning from others. And the more that they can then use others to adapt what's going on inside of themselves and to understand it, the better. So what does all of this help us understand in terms of what is important in treating people who have been traumatized? Well, we think that the therapeutic relationship is vital in this understanding. We also think that social connection is absolutely center stage. The body also needs to be thought about. We are not just disembodied minds. And containment of the patient, the therapist, and more broadly, the institution. So the implications then for treating people with complex post-traumatic stress disorder. Now, the italics are the recommended guidelines that we have from international societies on trauma. They talk about stabilization and safety first, then trauma therapy, then reintegration. We think about it at the Tavistock slightly differently. We see the first step is actually vital to have therapeutic engagement, which gives stabilization and safety. We see the trauma work as being around remembrance, to remind you that remembering is what I was saying is both having the words and the affect, and that remembering then requires mourning, and that endings and reparation are vital to the third stage. So when we are thinking about engagement, we think it's vital to be able to psychoeducate our patients. This links back to the notion of the window of tolerance, helping people have their own skills to be able to manage hyperarousal, for instance, through relaxation exercises, or to manage hypoarousal and dissociation through grounding exercises. We think it's vital they have an understanding of what's happening to them and have an understanding of how to work on their self-care and on their social support network. And that's all part of the psychoeducation that we offer. We see the continuity of the therapist-patient relationship as central to the work. However, we also think flexibility is vital, both in terms of what modality of treatment might be helpful, and we've heard about a whole variety of modalities today, and maybe that just highlights how important it is to have different tools available to us. But flexibility can also be important in terms of titration of frequency of contact and so on. And in thinking about the body, we think it's really important to be able to look at non-verbal engagement, to be able to think about this in terms of the biobehavioral synchrony, what's happening between the two of us in the room. We make use of a variety of stabilisation techniques from other modalities to be able to help people be in the room with us and to manage not going into those extremes of the window of tolerance. We constantly keep an awareness of our countertransference and transference, although we may not be using that in terms of psychoanalytic techniques. And we think about containment because we're aware that very powerful countertransferences are likely. When we're working in this psychoanalytic framework, we hold that notion that I was describing of the repetition compulsion, the various ways in which the different enactments can occur through identifications with different parts of the traumatic scenario, so that we are always thinking about who am I at this moment to the patient. We think it's vital that there is good containment of this very powerful experience for the therapist and to look at a variety of ways for that to occur, and that includes institutional containment. And we also think it's really important that the therapist thinks about their own self-care, really looking after their own body and mind and social supports. In looking at the trauma work, so the second stage, we may use other modalities, especially if there are a lot of re-experiencing symptoms, nightmares, flashbacks, and so on. We make use of groups for childhood sexual abuse, trauma art therapy groups, mentalization-based groups. Now, we see groups are also part of improving social connection, so we see that it causes a kind of double function. We have this flexible approach to titration, and we use non-verbal adjuncts, particularly our trauma yoga group, but we see that other non-verbal adjuncts are important. And I just wanted to bring Van der Kolk in again to say that, and of course I'm probably speaking to the converted here, but how important something like yoga can be, and that all of the functions of yoga have been shown to affect the neurobiological functioning in the areas that often impact on trauma. And with all of this, what we might start to see is that some of our trauma patients begin to become psychotherapy, psychodynamic or psychoanalytic patients. And these are the kinds of things that we might look for. It's often really interesting to see how patients who are having re-experiencing trauma dreams move to having more symbolic dreams over time. They're less full of action and more able to think, more able to regulate their affects, and they may be able to tolerate a transference interpretation. So we would see then the psychoanalytic trauma work is working in the transference, acknowledging that there will be the pull to the enactments. And I think in relation to the kinds of difficulties that there can be, particularly for trauma patients in terms of power dynamics and the sense of a repetition that can occur, we really focus on working alongside our patients. We think it's really vital to look at the importance of narrative and to attend to loss and mourning. And when we talk about endings and reparation, we are thinking that this again brings up the mourning process of all of the losses that have occurred. We see that reintegration is reintegration into the present, into new patterns of relating, into their current life, and getting back into their body. We emphasize again the importance of social connection, whether that's familial or more broadly. And we also think in this last phase, it's particularly helpful to look at altruistic and reparative actions that the patients can take. And finally, just to end, I wanted to quote, first of all, Irvin Yalom, who says that the therapist must strive to create a new therapy for each patient. But then the quote below, which is from Michael Mitfer, who has developed MDMA-assisted psychotherapy for PTSD, he says, maybe the therapist must strive to allow and encourage each patient to create a new therapy for themselves. Thank you.
Thanks very much, Joe. That is absolutely fabulous. We have had loads of questions, so I'm not going to sort of ask anything on my own behalf, but I'm going to sort of raise the questions. Firstly, Shekhar, I think one of the questions has been about the cultural impact. And in a country where children are revered and indeed worshipped in many sort of situations, how do you see the impact of trauma on different genders in particular? And then I'll come back to Joe on that.
There are a couple of responses, Dinesh, historically or culturally, if you look at old texts and the way childhood was conceptualized, and the kind of vulnerability that children have now, particularly in the last, let's say, 25 or 30 years, where child protection has become such a major issue. There are many ambiguities that exist in civil society. For example, the ambiguity between adult unemployment and child labor. That's one issue we need to keep in mind. The other interesting fact is that the study that was done by the Government of India, Ministry of Women and Child Development, actually found that the sexual abuse of boy children was as much, if not more, than girl children. And somehow in the whole hierarchy of gender and power structures, this issue has got a little obfuscated. So what we have tried to sort of understand is that child sexual abuse is a children and childhood issue. It is a sex and sexuality issue. It's an abuse, violation, violence issue. It is a gender and patriarchy issue, and it's a power and domination issue. In a given case, one more than the other. And which is why in a given case, we look at the valence of what actually played out in the experiences that the children had endured, and then tailor the therapy to suit that individual child's predicament and inner processing. These are some initial responses, Dinesh, to what you said. There's a lot more that I could work on as we go along.
I think that kind of raises sort of very interesting questions about the nature of society and sort of patriarchy and the sex expectations and gender roles and gender role expectations, etc. Joe, you're nodding your head.
Yeah, I would absolutely agree. I think it's really interesting that the statistics that you just gave there, Shekhar, because we are seeing a growing number of men now coming forward with historical child sexual abuse, which in the past, I suspect, has probably in a multifactorial way been something that has been impacted on because of culture, because of gender differences, that men, perhaps through shame, have found it very difficult to come forward. I suspect that over time it will be much less gendered than it has been in the past, in the same way that we have seen over certainly the 20 years that I've been working in this field, a move from small numbers of women coming forward with this history, and if they did come forward, often not immediately disclosing. There is a sense that now it's becoming something that people present with, this history, I've been abused. I think society has a long way still to go, and we're at the end stage here in the UK of the independent inquiry into childhood sexual abuse. It will be interesting to see whether or not the recommendations that are made truly capture what we might need to be thinking about as a society. Because I think that, yes, it's about patriarchy, but I think ultimately it is also about the terrible imbalance of power and violence that is a part of that.
And another question which has come up while I've got you, Joe. So individuals who have sort of distorted behavioral patterns, do they change their behavior by comparing themselves to typical people, or do they just sort of suppress their behaviors? And those behavior changes, I mean, how do they affect, are related to cognitive effect?
That's not an easy question, is it? But I suppose what I would say actually is I would go back to what I was saying right at the start about Freud and Ferenczi. I don't think these things are ever either or. I think that inevitably there can be something about social learning, which is linked to what I was describing about epistemic trust, that once people can start to be open enough to notice and be impacted upon by others' behaviours, then yes, it may well be that they adjust according to what they see in others. But there is also the question of what might need to happen internally for that to go on. And that does require the development of trust and the capacity to be able to feel safe enough to look around at what the social connections are.
What do you think, Shekhar?
There's another perspective that I wanted to share going ahead in this discussion and on this theme. This is related to the point that I had made about the importance of context, and Joe did give, not exactly a counterpoint, but a perspective where one has to take not just the context, but the way in which an individual has experienced the, particularly when we work with young children, because a lot of their experience is not internalized as language, it's internalized as sensations and smells, and therefore how a therapist needs to be skilled with techniques that go beyond language, which is the use of play and the use of art to actually engage with children to do trauma-related work. But context begets experience, experience begets an inner processing, that begets an emotion, and emotion determines behavior. So two children may come from exactly the same context, let's say of lack of supervision, neglect. Both of them have had exactly the same experience of abuse. But depending on how they internalize it, the emotions may differ. And if the internalization is one which is based on a pernicious and a toxic culture of patriarchy and gender and power, and the internalization is therefore one of helplessness, and the limitations of one's mobility and one's choice, then the emotion is one of anxiety and or sadness, and then you have self-cutting or withdrawal as behaviors. Whereas if this child has been in a culture or in a family where the agency of children is recognized, and there is a culture of conversations in the family, the child's inner voice may well be, how dare he do this to me? And the emotion will be one of anger. And therefore, the behavior of acting out. Similarly, 4 children may have exactly the same manifest behaviors, let's say school refusal, but in one of them, the context, the experience may be of a learning problem, in another, it may be bullying, and in a third, it'll be sexual abuse. So in any therapeutic approach, the relationship between this nuanced clinical understanding of the relationship between context, experience, internalization, emotion, and behavior, and then applying the kind of therapeutic strategies that Tavistock follows, that Joe has so eloquently and so evocatively shared with us, makes sense, because they work in a context where even the child that you're working with understands that this is not merely alleviation of symptoms, but it's an engagement that is healing centered.
Thanks. While I've got you, Shekhar, another question that came was about the role the media plays in, kind of hashtagging abuse or whatever, which means that people are getting in a sort of artificial identity or real identity for them. So what should the message to the media be? What should we be doing or saying?
There are several, to use media as a strategy. Some of you may be familiar in 2015 that the Juvenile Justice Act in India changed because of what is known as the Nirbhaya episode. And there was a lot of question and a lot of debate about women's safety, and understandably so. And one is concerned about women's safety. And but that debate is incomplete, because the debate should not be only about women's safety; it should also be about women's freedom. It's an incomplete debate.
Male children's safety as well.
Yes, exactly. So, coming back to the whole issue of the predicament of a male child who is sexually abused and who incidentally happens to be gay. And the notion, because you're heteronormatively socialized, that so there is a pernicious combination of patriarchy, heterosexism, and homophobia on the one hand, and then of patriarchy, misogyny, and gynophobia on the other hand. So the whole issue of toxic masculinity and all the locker room stuff that goes on. And so this is the kind of debate that needs to come in media, so that the notion of relationships that are truly egalitarian, and whether it's in classrooms or whether it's in families, that these become spaces where we really exchange knowledge and develop knowledge jointly about the nature of relationships, about the nature of power and domination, about schisms that exist. And masculinity is not so much about the experience of absolute power, it's about the experience of entitlement to power. Because while in gendered and patriarchal societies, one may argue about men being more powerful than other women, but the truth is that there are men who are powerful than other men based on caste or based on economic status. And where does this sense of entitlement come from? And I remember Michael Kaufman and Michael Kimmel, both of whom speak so much about masculinity in a TED talk that he'd given. There were a group of women, and the white woman spoke about how oppression is an experience common to all women. And the black woman put up her hand and said, when you look at the mirror in the morning, what do you see? And the white woman said, I see a woman. And she says, see, that's the problem. When I look at the mirror, I see a black woman, because privilege is invisible to those who have it. So these ideas of privilege, of entitlement, of power and domination in the media and in schools, so that the socialization of boys now is such that they grow up into egalitarian thinking people as adults.
Thanks very much, Shekhar. Joe?
Well, I absolutely agree with what you're saying, Shekhar, but I find myself wondering whether actually the messages to the media need to be a little bit more basic, first of all. one of the things that I find really very distressing in many of the people I see, and particularly the younger age group, is how little there is an understanding of self-care of the mind and body, managing one's own affective state, the capacity to be able to mentalize, those kinds of things that end up leading, for instance, to the sort of enormous number of adolescents in this country who self-harm, who have eating disorders, because they don't know, first of all, how to manage themselves, but also how to engage with others. And I thought what you were saying around this issue of dependency and personal autonomy was really interesting in that too, because it seems to me that those are part of the messages that need to be got across more broadly.
Yeah. It would need to be windowed. Yeah. The strategy has to be windowed to look at some basic stuff. When you open that window, you get into a somewhat deeper and a more nuanced area to more complex
Absolutely.
areas.
And it's interesting because we've been getting a little bit of that in this COVID crisis, that there has been some kind of well-being messages that have come out. But I think that it needs to be more broadly based in terms of children just learning about relationships in their own bodies and minds.
On that note, thank you both very much for a fabulous session. Thank you, Nimhans and Tavistock, and I very much hope that this is the beginning of a long and beautiful friendship. Thank you, everyone, for tuning in, and tune in tomorrow for the second session. Thank you very much.
Thank you very much, Dinesh. Lovely to meet you, Joe. Take care.
Thank you, Shekhar. It was great. Thank you.
Thanks, Joe.
Thank you, everyone. Thank you, Professor Dinesh, Professor Shekhar, and Dr. Joanne for a wonderful session that we have had. And I think it's a really fitting way to actually bring an end to the first day of the Nimhans Tavistock Psychotherapy Conference. We will meet you all again tomorrow at 2:30, and we will have a couple of other sessions as well as the panel discussion, wherein we will be taking up a lot of questions. I know there have been a lot of questions that have been put up on the chat. We're actually going to put a lot of those questions down, and a number of them would actually be discussed during the panel discussion tomorrow as well. Right? So have a safe Friday evening, and we will see you tomorrow at 2:30 in the afternoon. Bye.
Bye.
Arun sir.
Hi.
Hi, good evening, sir. It went on very well. Congratulations. And
thank you very much. Thanks for all your support.
Thanks for the support. Yeah.
Always there, sir. Thank you so much, and being pleasure being a part of this, sir. So shall we end it here, sir? And tomorrow, as usual, Prashant will start the session almost 1 hour before, so that if anything needs to be checked, we can check again, sir.
Sure. What is the maximum attendance today? Any point
today, I could see around 800, sir.
800.
Nearing 800.
Okay.
That's the peak I could see, sir.
Sure.
Started with 400. Yeah, 821 is the peak. Around 800, and I started with 400 at 2:30, and just within half an hour it almost touched 600. So it consistently maintained from there.
Thank you then. Thank you. We'll meet you all tomorrow.
Wonderful, sir. Meet you tomorrow. Bye, sir. Okay, Prashant. Yes, Prashant.